Namaskar and a very good morning to all present here. On behalf of Sanchi's team, I am Manisha Tripathi from Access Health International, and I would like to take this opportunity to welcome all of you on this auspicious occasion of the 4th year anniversary celebration of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana in Uttar Pradesh. कार्यक्रम का शुभारंभ करेंगे हम अपने विशिष्ट अतिथियों का मंच पर स्वागत करने के साथ। आमंत्रित करना चाहूँगी प्रमुख सचिव श्री पार्थ सारथी सेन शर्मा सर को मंच पर। सर प्लीज मंच पर आएं। श्री रविंद्र सर, सचिव चिकित्सा स्वास्थ्य एवं परिवार कल्याण। श्रीमती संगीता सिंह, सीईओ सांचीज। श्रीमती रेणु वर्मा जी, महानिदेशक परिवार कल्याण। डॉक्टर सुधा चंद्रशेखर, एग्जीक्यूटिव डायरेक्टर, नेशनल हेल्थ अथॉरिटी। श्री देवेंद्र खंडायत जी, डेप्यूटी डायरेक्टर, बिल एंड मेलिंडा गेट्स फाउंडेशन। डॉक्टर बालेंद्र प्रताप सिंह, पीएमजे नोडल ऑफिसर, किंग जॉर्ज मेडिकल यूनिवर्सिटी। प्लीज तालियों की गड़गड़ाहट के साथ हमारे विशिष्ट अतिथियों का स्वागत करें। ऐसा रोज रोज नहीं होता कि हम 4 वर्ष की वर्षगांठ किसी कार्यक्रम की जल्दी जल्दी मनाएं। इट्स वन ऑफ दी ओकेजन, सो आई वुड रिक्वेस्ट ऑल दी प्रेजेंट गेस्ट टू प्लीज मोमेंटम बनाए रखें और इंस्पिरेशन बनाए रखें। As Mahatma Gandhi once said, even a single lamp can dispel the deepest darkness. We hope that by lighting this lamp, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana shall be the harbinger of light and dispel the deep darkness of catastrophic social impoverishment led by health. On this note, I would like to request all the honored guests to please light the lamp. तालियां बजती रहती हैं तो मान भी बढ़ा रहता है और सम्मान भी बढ़ा रहता है। तालियां बजती रहनी चाहिए। ABPMJY was launched by the Honorable Prime Minister of India in Ranchi, Jharkhand, and by the Honorable Chief Minister of Uttar Pradesh, Shri Yogi Adityanath ji, in our state on 23rd of September 2018, and that marks 4 years of successful implementation in the state of Uttar Pradesh. This Yojana is the world's largest health insurance scheme, which provides 5 lakh annual health insurance cover to poor and vulnerable beneficiaries of Uttar Pradesh. This scheme is the most ambitious health scheme ever to expand universal health coverage designed to meet the Sustainable Development Goals and its underlying commitment. But as they say, any scheme is only good as the organization and implementing it. We would like to honor all the guests sitting on the stage by requesting Srimati Sangeeta Singh ji, CEO Sanchi's, to welcome the guests one by one. We will begin with Principal Secretary Sir. Ma'am, please welcome Ravindra sir. CEO Madam would now welcome the DG Family Welfare, Renu Ma'am. She would now welcome Dr. Sudha Chandrasekhar, who has joined us from Delhi National Health Authority. CEO Sanchis would now welcome Shri Devendra Khandayat ji, Deputy Director, Bill and Melinda Gates Foundation, who has also joined us from Delhi. Madam will now welcome Shri Dr. Balendra Pratap Singh, KGMU. Thank you so much, ma'am, for doing the honors. And as I just now mentioned, any scheme is only as good as the organization implementing it, and any organization is as good as its leader. And I'm always proud to be introducing CEO Sanchis, always from the dais. She is a leader who knows the way, who goes the way, and shows the way, and that is very hard to find usually. Srimati Sangeeta Singh ji has been at the helm of the scheme from its very beginning and has guided our path through her rich experience and nuanced approach. She has not only been known to have talked the talk, but also walked the walk, and proven to not just the Sanchis and Uttar Pradesh government, but also to the world, of how vision and diligence are sanctimonious in the success of such a expressive scheme like Ayushman Bharat PMJ. I would like now to invite the Chief Executive Officer of Sanchis, Srimati Sangeeta Singh ma'am, to set the context for today's session and throw some light on the implementation experience and, of course, challenges of the 4-year journey. Ma'am.
Thank you, Manisha. Pramukh Sachiv Mahoday, Sachiv Health Shri Ravindra Singh Sir, Shri Devendra Khandayat ji, Dr. Sudha, DG Ma'am and Dr. Balendra. ये बड़े हर्ष का विषय है कि हम यहाँ आयुष्मान भारत प्रधानमंत्री जन आरोग्य योजना के 4थे वर्ष के समापन के अवसर पर और 5वें वर्ष के शुरुआत के अवसर पर यहाँ उपस्थित हैं। इस एस्टीम्ड हॉल में जो कि हमारा पार्टनर है KGMU और एक बहुत अच्छा परफॉर्मर है स्कीम के अंतर्गत, तो ये बहुत अच्छा कॉन्टेक्स्ट है जिसके अंतर्गत हम लोग यहाँ पे उपस्थित हैं। 4 साल एक लंबा वर्ष होता है, थकान भरी सफ़र है, आई कैन गारंटी दैट। पर जैसे कि एक शेर है, प्रॉपर वर्ड्स मुझे याद नहीं है, बट कॉन्टेक्स्ट यही है कि वो क्या हुआ कि 2 कदम चले और मंजिल आ गई, तब तक क्या मज़ा जब तक पैरों में कुछ थकान ना हो। तो वो थकान महसूस कर रहे हैं, पर साथ ही इस संकल्प के साथ हम आगे बढ़ रहे हैं कि एक नई ऊर्जा के साथ हम 5वां वर्ष शुरू कर रहे हैं और बेहतर परफॉर्म करने के लिए और बेहतर सर्विस देने के लिए हम सब प्रतिबद्ध हैं। सो इफ वी स्टार्ट, शुरुआत में जो हमारी क्रियान्वयन की प्रगति है उसके बारे में मैं प्रारंभ करना चाहूँगी। जो नंबर ऑफ कार्ड्स, हमारा डेटाबेस लगभग 1.73 करोड़ परिवारों का है। उन परिवारों के सापेक्ष अब तक जो हमने कार्ड, आयुष्मान कार्ड बनाए हैं, वो 2.16 करोड़ कार्ड बना लिए हैं। अभी भी एक लंबा सफ़र बाकी है, गैप है, पर हम ऊर्जा के साथ इसमें लगे हुए हैं। सारे जनपद और हमारा एजेंसी, हम लोग इसको साथ में बढ़ने की कोशिश कर रहे हैं। डेटाबेस एक चैलेंज है, पर ऑफ कोर्स उसको भी गैप करने का प्रयास NHA और स्टेट हेल्थ एजेंसी दोनों मिलकर कर रहे हैं। लगभग जो कार्ड्स बने हैं उसमें 92% लाभार्थी ऐसे हैं जिनका आधार के साथ मैपिंग करके ये कार्ड बना है। सो वो आधार का बेस जब हमें मिल जाता है तो बहुत सारी अन्य स्कीम्स के साथ उनको मैप करने में या उनको आइडेंटिफाई करने में या लेटर ऑन किसी और, या जैसे हम आभा ID की बात कर रहे हैं, NDHM बाद में डेवलपमेंट आया, तो आभा ID की बात करते हैं, तो ये सब उसका एक सबसेट हो जाता है और ये एक बहुत इंपॉर्टेंट स्टेप है उसको आगे ले जाने के लिए। जो हमारे टोटल डेटाबेस है उसमें लगभग 51% परिवार ऐसे हैं, 88,77,000 परिवार, जिनमें कम से कम एक कार्ड परिवार के पास है। मतलब उस परिवार तक कार्ड पहुंच चुका है और अब उसको अवेयरनेस है कि ये योजना क्या है और इसका लाभ कैसे लिया जा सकता है। अगर जो हम जितने कार्ड्स बने उनके सापेक्ष हम अगर देखें कि कितने लोगों ने बेनिफिट अवेल किया, तो ये लगभग 15.18 लाख लोग हैं जिनको कि बेनिफिट मिले योजना में विभिन्न प्रकार की सर्विसेज के लिए। और 42% इन पूरे 15 लाख में से 42% प्रोसीजर्स जो थे वो टर्शरी केयर के थे, जिनमें से कैंसर, न्यूरोलॉजी और हार्ट रोग के भी प्रोसीजर्स काफ़ी बड़ी मात्रा में थे. सो टर्शरी केयर का एक अच्छा क्वांटम टेकअप हुआ है यहाँ पे. जो हमारे पार्टनर्स जो चिकित्सालय हमारे साथ आबद्ध हैं अभी तक, वो 3,156 चिकित्सालय, 3,156 हॉस्पिटल्स वी हैव बीन एबल टू इम्पैनल, आउट ऑफ विच 1,111 हॉस्पिटल्स सरकारी हैं और 2,045 चिकित्सालय हमारे प्राइवेट हैं, जिनमें मेडिकल कॉलेजेस शामिल हैं, प्राइवेट मेडिकल कॉलेजेस शामिल हैं, मल्टी स्पेशलिटी केयर हॉस्पिटल शामिल हैं. सो एक अच्छा क्वांटम हमने कवर किया है. और उत्तर प्रदेश वन ऑफ द फ्यू हाईएस्ट इम्पैनलिंग स्टेट्स है देश में, जो कि सबसे ज़्यादा जिन्होंने हॉस्पिटल्स को इस योजना के अंतर्गत आबद्ध किया है. योजना के अंतर्गत आबद्धता एक सिग्नल है. इट इज नॉट कि ये आबद्ध किया तो हम अपनी डींग हाँक रहे हैं या हम अपनी शेखी बघार रहे हैं, बट इट इज जस्ट एन इंडिकेशन ऑफ द फेथ दैट हॉस्पिटल्स हैव इन द स्कीम, इन द पॉलिसी दैट हैज बीन इम्बाइब्ड इनटू द स्कीम, जिसके माध्यम से वो योजना में जुड़ के सर्विस प्रदान करना चाहते हैं. एंड इफ मोर प्राइवेट हॉस्पिटल्स हैव कम अप, मोर मल्टी स्पेशलिटी हॉस्पिटल्स हैव कम अप, इट इज imperative to say that they want to not only to serve, but they feel that there is some quantum of benefit to them also, because ultimately these are all non-profit की जगह कुछ profit hospitals भी इसके अंतर्गत हैं. So we can safely say that considering कि एक package rates को लेके issues होते हैं, hospitals may not be happy, may be happy, payments को लेके delays की बात की जाती हैं, but in general the way the empanelment has proceeded has gone to show that despite the fact that there was no scheme running in the state when Ayushman Bharat started, उसके 3 साल पहले कोई स्कीम नहीं थी और हॉस्पिटल्स के पेमेंट्स हेल्ड अप थे, इंश्योरेंस कंपनीज के डिलेज थे. सो डिस्पाइट दैट, द फैक्ट दैट मोर एंड मोर हॉस्पिटल्स आर नाउ कमिंग अप टू बी पार्ट ऑफ द स्कीम एंड दे आर गिविंग एप्लीकेशंस फॉर एम्पैनलमेंट गोज टू शो दैट कुछ तो हम ठीक कर रहे होंगे. इन जो हमने लोग ट्रीट किए हैं उनमें 296 करोड़ के इलाज लाभार्थियों ने बाहर के स्टेट्स में भी लिए हैं, बिकॉज स्कीम का एक बहुत इंपॉर्टेंट पार्ट पोर्टेबिलिटी है. जो उत्तर प्रदेश का पेशेंट है वो बाहर जाके भी ट्रीटमेंट ले सकता है. सो बहुत सारे पेशेंट्स ऐसे हैं जो कि बाहर जाके उन्होंने ट्रीटमेंट लिए हैं. मे बी इट इज अ सिग्नल फॉर आवर हेल्थ इंफ्रास्ट्रक्चर to be made more sound, to be made more receptive and to be more approachable. क्योंकि वो अगर बाहर गए तो and they spend their money for traveling, तो इसका मतलब हमारे प्रदेश में उनको या तो उतना कॉन्फिडेंस नहीं आया या उनको सुविधा बाहर के प्रदेश के हॉस्पिटल्स में ज़्यादा मिली. हमारे कॉन्टेक्स्ट में इट इज़ नॉट डिफरेंट, बिकॉज इन एनी केस वी आर ट्रस्ट मॉडल, जो भी ट्रीट करेगा उसको हम पे करेंगे. बट इन कॉन्टेक्स्ट ऑफ आर थिंकिंग एंड आर इंफ्रास्ट्रक्चर, दैट मे बी एन इम्पॉर्टेंट थिंग टू नोट. 91% दावों का निस्तारण हम प्रयास करते हैं कि जल्दी से दावों का निस्तारण करें. ऑफ कोर्स इट्स अ टीडियस एंड कम्बरसम एंड अ टेक्निकल प्रोसेस, उसमें कुछ टाइम लगता है, बट 91% हमारा आज की डेट में दावों का निस्तारण प्रतिशत है. अब अगर हम 4 वर्ष की उपलब्धियों की बात करें, तो अगर फिगर्स और किस तरह से हमने इसको टेकअप किया उसकी बात करें, तो लैंगिक आधार पर जेंडर कोशेंट क्या रहा है इस योजना का, तो हम ये देखते हैं कि जो पुरुष संवर्ग को जो ट्रीटमेंट्स हुए हैं उसमें 56% के करीब पुरुष ट्रीट हुए हैं और 43% के करीब महिलाएं ट्रीट हुई हैं. आयु के आधार पर हमें जाएं तो लोएस्ट क्वांटम जो ट्रीटमेंट का है वो 5 to 14 इयर्स के ऊपर है, और जो लार्जर कॉन्टेक्स्ट है वो ऑफ कोर्स 15 to 29 या 30 to 44 हेल्दियर संवर्ग में जाना जाता है. ऑल्दो इनका भी काफी बड़ा प्रतिशत है, क्योंकि हम धीरे धीरे ये देख रहे हैं कि हीमोडायलिसिस जैसे प्रोसीजर्स या कैंसर जैसी बीमारियां यंग संवर्ग में भी धीरे धीरे ऑन द राइज हैं और बहुत ही यंग कॉन्टेक्स्ट में इनका ट्रीटमेंट्स हो रहा है. लेकिन लार्जर कॉन्टेक्स्ट में जो ट्रीटमेंट्स हुए हैं वो हायर एज ग्रुप के अबव 45 to 59 एंड 60 प्लस एज ग्रुप में उसके हिसाब से इनके ट्रीटमेंट्स हुए हैं. अगर हम वर्षवार जो हमने प्री ऑथराइजेशंस किए तो वो कैसे राइज हुआ उसका एक एग्जांपल है कि जो टोटल प्री ऑथराइजेशंस हुए हैं उसमें आप देखेंगे कि 2018 की जो ये फिगर है 15,409 की, ये सितंबर टू दिसंबर की है. सो विद इन दैट ईयर अराउंड 15,000 पेमेंट्स ट्रीटमेंट्स टुक प्लेस, बट 2019 से लेके स्लोली राइज हुआ है, और जो 2022 में ये फिगर सितंबर तक की है, तो 2021 में ऑफ कोर्स 2020 में वी सी अ स्लाइट लेस ऑफ अ राइज, बिकॉज ऑफ कोर्स वी ऑल नो इट वाज कोविड एंड प्रॉब्लम्स थी, बट 2021 में 4,51,051 ट्रीटमेंट्स के सापेक्ष अब तक this January to September 5,11,000 treatments have happened, which means कि ये figure constantly जो curve है, जो graph है, वो constantly एक steep rise के साथ बढ़ रहा है. So more and more treatments are happening. Of course, this is a clear byproduct of more hospitals being impaneled, more IEC being done, and more cards being made. So that translates into more treatments happening. गंभीर बीमारी के इलाज की अगर हम बात करें तो गंभीर बीमारियों पे भी इसी प्रकार वर्ष प्रतिवर्ष बढ़ोतरी हुई है जो गंभीर बीमारियां हैं. और कैंसर स्पेशली बिकॉज सेकेंड टेक्निकल सेशन में हम कैंसर के ऊपर विशेष तौर से बल दे रहे हैं और कैंसर को हमने एक इम्पॉर्टेंट अवयव के रूप में अपने साथ लिया है. कैंसर हॉस्पिटल्स को अपने साथ मिलाकर उनकी ट्रेनिंग्स शुरू कराई हैं और कई बार हम लोगों ने कॉन्फ्रेंसेस उसके संदर्भ में की हैं. तो कैंसर की अगर हम बात करें तो ये भी ट्रीटमेंट्स काफ़ी बड़ी मात्रा में यूपी में हुए हैं. अब अगर हम माहवार दैनिक औसत प्री ऑथराइजेशन की बात करें तो वही स्थिति है जो हमने कहा कि वर्ष दर वर्ष ये प्री ऑथराइजेशन बढ़ रहा था, जहां जनवरी 21 में जो प्रति माह अगर हम सिर्फ 1233 पेशेंट्स ट्रीट कर पा रहे थे, सो अगस्त 2022 में दैट हैज गॉन अप टू डेली, आई एम टॉकिंग अबाउट डेली एवरेज डेली औसत 2113 पेशेंट्स पर डे are being treated in August 21. That's an average, monthly average that we've taken. And September में possibly ये rise होगा. इसका एक सीधा example, reason जो हमें समझ में आता है, जो हमारी analysis है, वो है कि अक्टूबर 21 में हमने एक ऐसा डेटा को अपने मुख्यमंत्री जन आरोग्य अभियान के अंतर्गत माननीय मुख्यमंत्री जी के आदेश से सम्मिलित किया गया, जो कि 40 लाख परिवार अंत्योदय अन्न योजना के थे, जो आधार सीडेड थे, इजिली अप्रोचेबल थे, गांव में थे और हर महीने अपना राशन लेने आ रहे थे. तो जब डेटा सुगम होगा, सुलभ होगा और इजिली अप्रोचेबल होगा, तो फिर ऑब्वियसली कार्ड्स बनने की संख्या और लोगों की अप्रोचेबिलिटी भी बढ़ जाती है. सो अंत्योदय अन्न योजना के अंतर्गत जो डेली प्रियॉथ, हमारा दैनिक प्रियॉथ है, वो अराउंड 440 पर डे can go, the credit can go basically to the scheme that we have incorporated. और एक साल में important ये है कि 4 साल में हमने जो कवरेज किया, आपने देखा टोटल 51% कवरेज फैमिलीज का हुआ है. बट अंत्योदय अन्न योजना के जो लाभार्थी 40 लाख थे, उनका फ्रॉम अक्टूबर 21 टू टुडे विच इज अराउंड अ ईयर, उसमें लगभग 60% से अधिक लाभार्थी परिवार योजना के अंतर्गत कार्ड्स बन गए. सम्मिलित तो पहले से ही हैं, पर कार्ड्स हम उनके बनाने में सफल हो पाए हैं. अगर हम वर्ष बार चिकित्सालयों की बात करें, सो दिस इज अ क्यूमुलेटिव फिगर बेसिकली. सो फ्रॉम 1077 हॉस्पिटल्स एम्पैनल्ड इन द फर्स्ट ईयर, वी हैव मूव्ड ऑन टू 3231 हॉस्पिटल्स एम्पैनल्ड टुडे इन 2022. अगर चिकित्सालयों की सहभागिता की बात हम करें कि किस तरह के चिकित्सालय हमारे साथ काम कर रहे हैं और कितने एक्टिव कौन से तरह के अस्पताल हैं, सो इसमें क्लियर है कि जो सरकारी चिकित्सालय हैं उनका जो योजना के अंतर्गत योगदान है वो अनफॉर्चुनेटली 21% ही है. प्राइवेट हॉस्पिटल्स ज़्यादा एक्टिव हैं, बट बिकॉज द बेसिक क्राइटेरिया ऑफ द स्कीम इज दैट ये एनेबलमेंट है और एम्पावरमेंट है पेशेंट का, कि वो सिर्फ पब्लिक हॉस्पिटल्स पर डिपेंडेंसी ना हो, प्राइवेट हॉस्पिटल्स के अंतर्गत भी जाके वो बेहतर सुविधाएं अवेल कर सके. सो अराउंड 78%, 79% के करीब प्राइवेट हॉस्पिटल्स में ट्रीटमेंट्स पेशेंट्स द्वारा लिए गए हैं. अगर देखभाल के प्रकार की बात करें तो हमारा टर्शरी केयर अराउंड 42% है और सेकेंडरी केयर अराउंड 58% रहा है. सेकेंडरी केयर में जो ट्रीटमेंट्स हैं वो अराउंड बिलो 30,000 के करीब जो ट्रीटमेंट्स हैं, जिसमें डायलिसिस हो सकता है, जिसमें बुखार के ट्रीटमेंट्स हो सकते हैं, छोटे सर्जिकल प्रोसीजर्स हो सकते हैं. टर्शरी केयर जैसे हृदय रोग है, कैंसर के ट्रीटमेंट्स हैं, तो ये सारे उस हिसाब से हैं. अब अगर हम सस्टेनेबल डेवलपमेंट गोल्स में योजना के योगदान की बात करें तो अभी रिसेंटली एक इंडिकेशन आया है जो कि SRS बुलेटिन के अनुसार उत्तर प्रदेश में जो MMR है, मातृ मृत्यु दर है, उसमें रिडक्शन हुआ है 30 पॉइंट्स का, which is a great credit to the public infrastructure and the way the public health facilities have performed. But I may be fetching for comments. The contribution of Ayushman cannot be negated in this sense that जो आयुष्मान भारत योजना के अंतर्गत 21,000 से अधिक उच्च जोखिम वाली महिलाओं का सुरक्षित प्रसव कराया गया. सो उस फिगर के डाउनफॉल होने में पॉइंट्स में ही सही, पर हमारा योगदान सर हम आई वुड लाइक टू पॉइंट दैट आउट. वर्तमान एसआरएस बुलेटिन के अनुसार ही जो आईएमआर की दर है, मात्र शिशु मृत्यु दर जो है वो भी 4% में गिरावट आई है, विच इज अ ग्रेट अचीवमेंट। पर आयुष्मान के अंतर्गत उसमें, क्योंकि हमारे पास नियोनेटल पैकेजेस भी हैं, 17,000 से अधिक नवजात शिशुओं का उपचार इसके अंतर्गत हुआ है और उनको प्रॉपर्ली ठीक करके हमारे हॉस्पिटल्स ने वापस भेजा है। अब अगर हम फोकस करें कैंसर का, तो ये इंडिकेशन जो भी आयुष्मान के अंतर्गत, बिकॉज इट इज अ डेटा रिच एंड all of us are talking about big data in today's world, so उस डेटा से जो हमारे हेल्थ इंडिकेटर्स की तरफ हमें पॉइंटर्स मिल सकते हैं या किस तरफ हमें ज्यादा फोकस करना है या ज्यादा काम करना है, पॉसिबली वी कैन analyze the data to get in more health infrastructure and more understanding about that. So अगर हम उसकी बात देखें तो ये जो उत्तर प्रदेश का मैप है, कैंसर ट्रीटमेंट्स, ये पेशेंट डेटा है, इट इज नॉट वेयर दे हैव टेकन ट्रीटमेंट, इट इज द डिस्ट्रिक्ट दैट द पेशेंट बिलोंग टू। तो उससे ये क्लियर हो रहा है कि जो येलो वाले मार्क डिस्ट्रिक्ट्स हैं, मैक्सिमम पेशेंट्स हेल्ड फ्रॉम दीज डिस्ट्रिक्ट्स, कैंसर पेशेंट्स जो थे। और स्पेसिफिकली अगर हम माउथ कैंसर और ब्रेस्ट कैंसर की बात करें, जो कि ज्यादा प्रेवलेंट कैंसर्स हैं आज की डेट में, तो वो ये जिले थे जिनके अंतर्गत ये डिस्ट्रिक्ट्स जो ज्यादा प्रेवलेंस है जहां पे। सो पॉसिबली वी कैन डू एन एनालिसिस एंड अंडरस्टैंड कि यहाँ पे क्या ट्रिगरिंग फैक्टर्स हैं, क्या लाइफस्टाइल चीजें हैं, एंड बिकॉज वी हैव HWCs ऑन बोर्ड, वी हैव NHM ऑन बोर्ड, वी कैन डू अ ग्रेटर एनालिसिस। हम ज्यादा सिनर्जी के साथ हम इसको ज्यादा एनालिसिस करके पॉसिबली एक डीप इंटरवेंशन इसके सेंस में हम ये प्रोवाइड कर सकते हैं। अगर हम निजी चिकित्सालयों की भागीदारी की बात करें, तो जो प्रयास हमने किया है कैंसर के कॉन्टेक्स्ट में वो यही है कि चिकित्सालयों के लिए हमने वेबिनार्स अलग अलग ऑर्गेनाइज किए, और जो स्टैंडर्डाइजेशन है कि उस इलाज को मानकीकृत करने के लिए राजकीय और निजी चिकित्सालयों में जो एक मानकीकृत करने की बात है, विच डॉक्टर सुधा विल बी मोर एबल टू एक्सप्लेन, वो हमारा प्रयास है कि हम एक स्टैंडर्ड ट्रीटमेंट गाइडलाइंस का इनकॉर्पोरेशन करके कैंसर ट्रीटमेंट्स को एक मानकीकृत दिशा की तरफ सजेशंस ले सके। ऑफ कोर्स पॉलिसी डिसीजन इज विद NHA, बट उसको लेकर भी एक वर्कशॉप्स वी हैव ऑर्गेनाइज्ड। जो आगे हमारी रोड मैप है वो बेसिक है। नंबर 1, ज्यादा से ज्यादा लोगों तक योजना का लाभ पहुंचाएं। तो जो हमारा गैप है आयुष्मान कार्ड मेकिंग में, उसको हम फुलफिल करना चाहेंगे। जो हमारा पर्यवेक्षण और अनुश्रवण तंत्र है उसको बहुत सुदृढ़ करेंगे और उसको आगे विकसित करने की कोशिश करेंगे, सो दैट फ्रॉड या मिसयूज को हम मैक्सिमम कंटेन कर सके। वो एक इंपॉर्टेंट चीज है जिसको हमें देखना ही है और जिसकी वजह से योजना आगे सुचारू रूप से आगे बढ़ पाएगी। राजकीय चिकित्सालयों का, एंड नॉट ओनली राजकीय, आई वुड से प्राइवेट हॉस्पिटल्स की भी सहभागिता हम कितनी ज्यादा बढ़ा सकते हैं इसके अंतर्गत, उसकी बात हम करेंगे। फिर 4 वर्ष जो हमारा डेटा है उसको हम नीति निर्धारण, सम काइंड ऑफ पॉलिसी मेकिंग, जो इंटरवेंशंस की बात मैंने अभी करी थी, उसको लेकर हम कैसे यूज कर सकते हैं। पॉसिबली वी कैन गिव द गवर्नमेंट फ्यू सजेशंस। Of course, कैंसर को लेते हुए we will have to have a more deeper intervention, and larger institutes like KGMU can support us in that. एंड जो इंटर डिपार्टमेंटल कोऑर्डिनेशन है वो लास्ट ईयर में बहुत स्ट्रांगली हमारे कॉन्टेक्स्ट में और हमारी वर्किंग में निकल के आया है। इंटर डिपार्टमेंटल कोऑर्डिनेशन इन द सेंस कि अब डिफरेंट डिपार्टमेंट्स के लोग हमारी इस योजना में हमारा सहयोग प्रदान कर रहे हैं। जैसे पंचायत सहायक जिनके पास उस तरह का इंफ्रास्ट्रक्चर अवेलेबल था कि वो आयुष्मान कार्ड बनाते, लार्ज नंबर में उनके आईडीज क्रिएट हुए हैं और वो गांव में रहकर उनका जनरेशन कर रहे हैं। HWC में भी हम एक बोथ वेज रेफरल सिस्टम वी आर ऑन द वर्ज ऑफ मेकिंग इट, सो दैट जो हमारे हेल्थ एंड वेलनेस सेंटर्स हैं वो इसमें एक लार्जर रोल प्ले करें, और जो NCDs हैं उसके माध्यम से हम इन जो डिजीजेस हैं, जैसे हम हीमोडायलिसिस की बात करते हैं, हार्ट प्रोसीजर्स की बात करते हैं, इनको कैसे एट द बिगिनिंग इंटरवीन करके, निप इन द बड करके हम एक ज्यादा हेल्दियर यूपी की तरफ आगे बढ़ सकें। सो दिस इज ऑल फ्रॉम माय साइड। आई होप वी हैव अ ग्रेट सेशन टुडे एंड थैंक यू वेरी मच फॉर योर पेशेंट लिसनिंग। थैंक यू।
Thank you so much, ma'am, for sharing your rich experience in implementation of the scheme, and as always, the various challenges that presented themselves and the way we worked on them as a scheme to ensure the success of the scheme. Last year, the theme for Ayushman Bharat has been the interdepartmental collaboration and convergence. इस साल मैडम की गाइडेंस में हमने एक कदम और आगे बढ़ाया है और कैंसर केयर जैसी गंभीर बीमारियों के ऊपर ध्यान आकर्षित करने का प्रयत्न किया है। इसी के साथ मैं स्वागत करना चाहूँगी श्री रविंद्र सर का, सेक्रेटरी डिपार्टमेंट ऑफ मेडिकल हेल्थ एंड फैमिली वेलफेयर, टू गिव हिज एड्रेस to the audience on his experience on 4 years of Ayushman Bharat PMJ journey in Uttar Pradesh, sir.
प्रमुख सचिव पार्थसारथी सिंह शर्मा जी, BMGFCA देवेंद्र जी, सुधाश चंद्रन जी, संगीता जी, रेणु जी और बालेंदु जी, और कुछ और जान पहचान के जो लोग मुझे दिख रहे हैं, सचिन गुप्ते जी हैं, निगी जी हैं, हमारे पुराने डीजी साहब, और कई और लोग हैं। कहा जाता है कि एक स्वस्थ शरीर में एक अच्छे मस्तिष्क का वास होता है, और जो आपका शरीर है उसकी आपकी रिक्वायरमेंट है, क्योंकि जो भी आप कुछ करना चाहते हैं वो आपके शरीर से ही शुरू होता है। तो एक बहुत इंपॉर्टेंट चीज है कि जो आपकी बॉडी है वो अच्छी स्टेज में रहे। दैट्स व्हाई वी आर स्लोली शिफ्टिंग फ्रॉम द कंसेप्ट ऑफ हेल्थ टू वेलनेस, कि खाली स्वास्थ्य ही नहीं, हम लोगों को ओवरऑल जो वेलबीइंग है, इसलिए हमारा जो मानसिक स्वास्थ्य है उसकी भी इसमें हम सम्मिलित कर रहे हैं। योगा एक इम्पॉर्टेंट इशू बनता जा रहा है, धीरे धीरे हम लोग इस ओर जा रहे हैं। तो एक बहुत इम्पॉर्टेंट योजना उस हिसाब से आयुष्मान भारत की जो ये प्रधानमंत्री जन आरोग्य योजना है बहुत इम्पॉर्टेंट है, क्योंकि फाइनली हम लोग लोगों को स्वास्थ्य की ओर ले जाने की कोशिश कर रहे हैं, उन लोगों को जिनको हम लोग ये मान के चलते हैं कि अपने मीन्स नहीं है। एक कवि ने एक जो अपनी तरफ से सिमिली दी है, वो ये दी है कि जो आदमी का जीवन है नदी की तरह होता है। जब स्टार्ट होता है तो पहाड़ों से स्टार्ट होता है और उछलता कूदता नीचे आता है, और जब मैदानों में आता है तो धीरे धीरे अंत में जाते जाते बहुत स्लो हो जाता है। तो टू अ लार्ज एक्सटेंट सही भी है कि शुरू में जब हम लोग बच्चे होते हैं और यंग होते हैं तो बहुत ज़्यादा ध्यान नहीं देते हैं, कूद गए कहीं से भी, तब कभी ध्यान नहीं आता कि घुटने बुढ़ापे में जाके रोएंगे। और धीरे धीरे जैसे जैसे एज बढ़ती जाती है 40s एंड 40+, तो मेडिकल रिक्वायरमेंट्स बढ़ती हैं धीरे धीरे। और यद्यपि हम लोग ये मान के चलते हैं कि जो ये योजना है ये गरीब लोगों के लिए, बट फैक्ट ये है कि अगर आज की तारीख में हम में से बहुत सारे लोगों को प्राइवेट हॉस्पिटल्स में जाके ट्रीटमेंट कराना पड़े तो कुछ दिनों के बाद हम लोग अफोर्ड नहीं कर सकते। इवन जो मिडिल क्लास के या हायर मिडिल क्लास के लोग हैं वो भी अफोर्ड नहीं कर सकते हैं। तो जो एक लॉन्ग टर्म ट्रीटमेंट है उसकी रिक्वायरमेंट उस एरिया में इंश्योरेंस की रिक्वायरमेंट हर किसी को है टू अ लार्ज एक्सटेंट। तो उस एंगल से ये एक बहुत अच्छी योजना शुरू की गई और आज उसको 4 साल पूरे हो रहे हैं। तो हम ये कह सकते हैं जन्मदिन है योजना का और उसकी बधाई हम लोग देते हैं योजना को। और जो काफी कुछ संगीता जी ने आपके सामने तथ्य जो है रखे, तो जो लोग हम लोगों के संग सरकार में काम करते हैं, तो वर्किंग विद द गवर्नमेंट इज अ वेरी हम्बलिंग एक्सपीरियंस, बिकॉज शुरू में आप लोगों को जो 100% अचीव करना चाहते हैं वो भी समझ जाते हैं कि गवर्नमेंट में आके 100% अचीव नहीं होता है, एंड यू स्टार्ट लाइकिंग मीडियोक्रेसी कि हाँ ठीक है इतना तक अचीव कर लिया तो काफी अच्छा हम लोगों ने कर लिया। बट देयर इज ऑलवेज अ चांस टू इम्प्रूव। सो मेरा मानना है कि जो हम लोगों ने किया है देयर इज अ लॉट वेयर वी कैन इम्प्रूव। और दूसरी चीज जो सीखते हैं सरकार में वो सीखते हैं स्टेक होल्डर्स। तो यहाँ हम लोगों के सब स्टेक होल्डर्स बैठे हैं। कुछ लोग ऐसे हैं जो हमारे संग काम करते हैं जिनके थ्रू हम डिलीवर करते हैं, कुछ लोग ऐसे हैं जिनके पास जाके हम कह रहे हैं भैया आपके लोगों के हॉस्पिटल्स हैं और आप लोगों के थ्रू हम लोग सर्विस डिलीवर करना चाहते हैं, क्योंकि हमारे जो हॉस्पिटल्स हैं उसमें हम लोग उतनी अच्छी सर्विस डिलीवर नहीं कर पा रहे हैं। फिर BMGF जैसे संस्थान हैं जो हम लोगों को लोगों तक पहुंचने में मदद करते हैं, क्योंकि आपने भी देखा होगा जो हमारा स्टेटिस्टिक्स सामने आया था कि उसमें धीरे 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 हम बढ़ रहे हैं, और जब बढ़ रहे हैं तो इसका मतलब है कि योजना की एक्सेप्टेबिलिटी बढ़ रही है। एक सेइंग और है, देयर आर 3 टाइप ऑफ लाइज, डैम लाइज एंड स्टैटिस्टिक्स। सो एक अच्छी चीज स्टैटिस्टिक्स के बारे में वो ये भी है कि आप जो पक्ष प्रस्तुत करना चाहें वो कर सकते हैं। तो अगर आप कर रहे हैं तो आप अपने पक्ष में करेंगे, जो आपका दूसरा यूज करेगा आप ही का डेटा यूज करेगा आपके अगेंस्ट कर सकता है। बट अगेन जो ओवरऑल प्रयास हम सभी लोगों का है, जितने भी स्टेक होल्डर्स यहां बैठे हैं सभी का प्रयास यही है कि जो हमारा टारगेट बेनिफिशियरी है उसको हम लाभ उपलब्ध करा सकें। और उनमें से कई लोग आए हैं, मुझे खुशी है कि वो लोग भी इस कार्यक्रम में हम लोगों के साथ आज बैठे हैं, क्योंकि असली स्टेक होल्डर जिसके लिए हम काम कर रहे हैं वो वही है। और हर एक स्टेक होल्डर की अपनी इंपॉर्टेंस इस योजना के सफल होने में है, क्योंकि जैसे जो प्राइवेट हॉस्पिटल के लोग आज हमारे पास आए हुए हैं, फाइनली हमने तो अपने हिसाब से स्कीम बना दी और उसको हम इम्प्लीमेंट कर रहे हैं, और जब तक हमको आगे कोई कहेगा नहीं कि ये समस्याएं स्कीम के अंदर हैं, तब तक उसमें इंप्रूवमेंट नहीं होगा। बिकॉज जब जूता काटता है तो पता चलता है कि कहाँ उसको ढीला कराना है। तो उसी हिसाब से आप सब लोगों का सिर्फ स्कीम को इंप्लीमेंट कर देने का नहीं है, एक फीडबैक जो लूप है वो हमेशा होना चाहिए, क्योंकि जो भी करेक्शन किसी स्कीम के अंदर होता है वो फीडबैक लूप से होता है। आपकी तरफ से आता है, शुरू में हम लोग रजिस्ट करते हैं कि नहीं हमारी स्कीम बहुत अच्छी बनी है, पर धीरे धीरे बार बार जब बोला जाता है तो आदमी को समझ में आने लगता है हाँ कुछ गड़बड़ है, तभी आदमी इतना बोल रहा है, और उसको फिर हम लोग ठीक करते हैं। तो आप लोगों का वो रोल बहुत इंपॉर्टेंट है। और 5 ऐसी संस्थाएं, बीएमजीएफ जैसी संस्थाओं में इंपॉर्टेंट रोल ये है कि आप एक दो तरह से काम करते हैं। फीडबैक तो आप दे ही रहे हैं हम लोगों को, बट साथ के साथ आप लोग हमारी बात को भी ले जाते हैं लोगों तक, और जो धीरे धीरे ये प्रतिशत है कार्ड बनने का, मुझे उम्मीद है, क्योंकि बनाना तो देखिए 100% चाहिए, और एनीथिंग विच इज लेस देन 100% इज बेसिकली शोइंग दैट वी आर नॉट सक्सेसफुल। बट जैसे मैंने कहा कि सरकार में आने के बाद पता चलता है कि देयर आर टू मेनी स्लिप्स बिटवीन द लिप एंड द कप। सो इवन जो प्राइवेट सेक्टर के लोग आए उनको भी ये पता चला कि इतने ज्यादा वेरियस फैक्टर्स आते हैं सरकार के अंदर कि उसको हम लोग धीरे धीरे ही शनि अग्रसरती ही कर सकते हैं, और उस दिशा में हम लोगों को काम करना है। तो वो आगे बढ़ रहे हैं हम, जो हम लोगों का डेटा बता रहा था स्टैटिस्टिक्स, लेकिन उसको और करने की जरूरत है, और आप लोगों का सहयोग मिलता रहेगा। हम लोग इस जो भी हमारे पास डेटा है इसको और इम्प्रूव कर पाएंगे, और धीरे धीरे जो हमारी योजनाएं हैं ये बेहतर लागू होंगी। इसी आशा के संग जब हम 5वें जन्मदिन को मनाएंगे तो और बेहतर स्थिति के संग यहाँ होंगे, और आप लोगों का सहयोग मिलेगा। इसी आशा के संग धन्यवाद।
धन्यवाद सर। स्क्रिप्ट के अनुसार तो एक बहुत ही साधारण सी लाइन में मुझे आपका धन्यवाद करना था, पर आपकी बहुत ही उपयुक्त लोकोक्तियों और कहावतों के लिए और आयुष्मान के जन्मदिन की बधाई के लिए सर स्पेशल थैंक यू। हम आगे भी आपसे स्कीम के इम्प्लीमेंटेशन के लिए गाइडेंस लेते रहेंगे। I would now invite Dr. Santosh Mathew, who is presently with us from Seattle, United States of America through Zoom, to share his insights. He is a former civil servant and is now the country lead public policy and finance, Bill and Melinda Gates Foundation. Over to you, Dr. Mathew.
Sharma ji, Ravinder ji, Sangeeta Singh ji, रेणु वर्मा जी, सुधा चंद्रशेखर जी, बलेंद्र प्रताप सिंह जी, और गेट्स फाउंडेशन से मेरा साथी देवेंद्र कंडाइल जी। On the occasion of the 4th anniversary of the launch of this very important scheme, प्रधानमंत्री जन आरोग्य योजना, साचिस को और उत्तर प्रदेश की सरकार को मैं बधाई देना चाहता हूं। 2.16 करोड़ बेनिफिशियरीज एनरोल्ड, 3000 से ज्यादा हॉस्पिटलों के एम्पैनलमेंट और 1740 करोड़ से ऊपर का ट्रीटमेंट्स कम समय में संगीता सिंह जी के नेतृत्व में साचिस ने काफी अच्छा काम किया है। मैं इस अवसर पर कुछ सुझाव देना चाहता हूं जिससे कि इस काम को और बेहतर ढंग से उत्तर प्रदेश में लोगों तक स्वास्थ्य सेवाएं अच्छी तरह से पहुंचा पाए। अगर एक साधारण व्यक्ति का अगर समस्या देखा जाए, जैसे कि सिर में दर्द, 15 दिन से सिर में दर्द हो गया, वो क्या करते हैं? कुछ लोगों से पूछते हैं, बगल के डॉक्टर या आरएमपी या प्राइमरी हेल्थ केयर सेंटर में जाते हैं, वहां से उनका जो है यात्रा शुरू होती है। पेशेंट का जो जर्नी अंग्रेजी में कहा जाता है, उस जर्नी का फ्रिक्शन हम कैसे कम कर सकते हैं। अगर 5वां साल में पीएमजेवाई की 5वां साल में, और दोनों पार्था सारथी सेन शर्मा जी और रविंदर जी को मैं कई वर्षों से जानता हूं और उनकी कर्मठ और लोकप्रियता के बारे में सब जानते हैं। अगर हम ऐसा व्यवस्था कर लें जिससे कि एक टोल फ्री नंबर पर उस व्यक्ति फोन कर पाए और उनकी समस्या का डिस्क्रिप्शन कर ले, और उस डिस्क्रिप्शन के आधार पर अगर उनकी एम्बुलेंस की आवश्यकता हो तो उसका व्यवस्था कर लें, अगर उनको टेली कंसल्टिंग की आवश्यकता है तो टेली कंसल्ट उपलब्ध करा दें, अगर उनको एक डॉक्टर की सलाह फिजिकल कंसल्टेशन के माध्यम से आवश्यकता हो, उसकी अपॉइंटमेंट उनको दे दें। कोई भी सेंटर में हो, डिस्ट्रिक्ट हॉस्पिटल में हो, अनुमंडल हॉस्पिटल में हो, हेल्थ एंड वेलनेस सेंटर में हो, या केजी मेडिकल कॉलेज में, अगर एक निश्चित समय पर उनको एक अपॉइंटमेंट दे पाए और ये कॉल सेंटर ये सुनिश्चित कर लें कि ये अपॉइंटमेंट फेल नहीं, तो आप समझ सकते हैं कि पेशेंट का और एक साधारण व्यक्ति का, उत्तर प्रदेश का साधारण व्यक्ति का क्या लाभ होगा, क्या उनकी समस्या कितनी अच्छी तरह से आप दूर कर सकते हैं। मेरा मानना है कि पीएमजेवाई का 4 साल की जो मैच्योरिटी, जिसमें 3000 से ज्यादा हॉस्पिटल के एम्पानमेंट हुआ है, और उसकी अतिरिक्त जो स्टेट गवर्नमेंट और सेंट्रल गवर्नमेंट की जो स्वास्थ्य संस्थाएं हैं, अगर इनकी एक अपॉइंटमेंट सिस्टम को सेंट्रली एक कॉल सेंटर का माध्यम से अगर मैनेज कर लिया जाए, बाय द वे ये हो रहा है कोलार जिला, कर्नाटका के कोलार जिला में डिस्ट्रिक्ट नर्व सेंटर की एक कॉन्सेप्ट के माध्यम से यही सिस्टम हो रहा है। कॉल करता है, टेली कंसल्ट उपलब्ध कराता है, लेकिन वो ट्रायजिंग के टाइम पर निश्चित तय करते हैं कि यार हम टेली कंसल्ट दे दें या डॉक्टर के लिए अपॉइंटमेंट दे दें। और उसके साथ अगर उत्तर प्रदेश में आप एम्बुलेंस की सेवाएं भी अगर जोड़ लें, लैब टेस्ट अगर प्रिस्क्राइब होता है, फिर लैब टेस्ट का भी अपॉइंटमेंट धीरे धीरे कैन गो स्टेज बाय स्टेज। पहला टेली कंसल्ट, उसके बाद डॉक्टर का अपॉइंटमेंट, और उसके बाद अपॉइंटमेंट फॉर डायग्नोस्टिक टेस्ट। अगर इसको अगर जोड़ा जाए तो मैं समझता हूं कि जन साधारण को इस सारा सेवाएं का असली लाभ कम फ्रिक्शन के साथ उपलब्ध कर पाएंगे। The second suggestion that I want to offer has to do with the quality of care. जैसे संगीता सिंह जी ने कहा था कि पीएमजेवाई के अंदर there is rich data that comes in because सारा claims फाइल होता है, और क्लेम फाइल करने के लिए काफी डॉक्यूमेंटेशन हॉस्पिटल को सबमिट करना पड़ता है। क्या यह संभव है कि इस क्लेम्स का डेटा को एक्सपर्ट डॉक्टर्स की माध्यम से एनालाइज करवाया जाए और स्टैंडर्ड ट्रीटमेंट गाइडलाइन से उसको तुलना किया जाए, और उस तुलना के आधार पर एक कंटिन्यूइंग मेडिकल एजुकेशन की प्रोग्राम, आजकल जूम कॉल्स जो है, जैसे अभी मैं सियाटल में बैठ करके आपके साथ बात कर रहा हूं, तो continuing medical education by some of the best medical experts in Uttar Pradesh aimed at those specific teams in those specific facilities जिसकी ट्रीटमेंट मोडालिटीज में और अपग्रेडेशन की आवश्यकता महसूस की जा रही है ऑन द बेसिस ऑफ दिस एनालिसिस। क्या इस तरह के काम भी हम स्वास्थ्य सेवा के बीच में हम करा पाएंगे क्या? तीसरा is the whole issue of timely payments to the empaneled healthcare providers. संगीता सिंह जी ने 91% का शायद डेटा हमें दिया था। ये अच्छा है कि सुधा जी के नेतृत्व में, डॉक्टर प्रिंजा की नेतृत्व में, आर शर्मा जी के नेतृत्व में हाल ही में नेशनल हेल्थ अथॉरिटी की तरफ से नया रेट्स अनाउंस की गई है, 2022 की जो रेट्स, which has been received very well by the market. पर उस एनहांसमेंट ऑफ रेट्स के साथ साथ एक डेफिनेटिवनेस अगर होता है फॉर द एम्पैनल हेल्थ केयर प्रोवाइडर्स की ये सब कागज सबमिट करने पर निश्चित रूप से हमारा पेमेंट 10 दिन के अंदर हो, इस तरह की एक कैलिब्रेशन ऑफ प्रोसेसेस अगर किया जाए तो मैं समझता हूं कि the level of comfort that hospitals will feel can be enhanced. उसी के दरमियान स्मार्ट पेमेंट्स की एक कॉन्सेप्ट में आप सबके सामने रखना चाहता हूं। स्मार्ट पेमेंट्स क्या होता है? अगर आप पीएमजेवाई के क्लेम्स का फाइलिंग और इसकी प्रोसेसिंग की अगर यात्रा को अगर थोड़ा विश्लेषण किया जाए तो सबसे पहले इसकी ये तो सारा तो कागजी जांच ही होता है, लेकिन पहले देखा जाता है कि क्या इसकी सही पैकेज को डिप्लॉय किया गया है। फिर डॉक्टर्स इसको एग्जामिन करते हैं कि क्या गिवन द सिम्टम्स, गिवन द कंडीशंस, वाज द ट्रीटमेंट गिवन अप्रोप्रिएट। फाइनली अकाउंट्स ऑफिसर जो है सैचिस में इसको एग्जामिन करते हैं कि इज द क्लेम अमाउंट राइट, डू दे हैव द बजट, एंड फाइनली द फाइल विल गो टू द सीईओ फॉर अप्रूवल। अगर इस रास्ता को, इस जर्नी को अगर एग्जामिन किया जाए तो क्या हम ऐसा एक सिस्टम चालू कर सकते हैं जिसमें कि डेफिनेटली जिसको एग्जामिन करके अपना सर्टिफिकेशन करने की जो रिस्पॉन्सिबिलिटी है, उस सर्टिफिकेशन की आधार पर can we not at least as a pilot case start releasing money to the government hospitals by reducing the number of layers through which it has to go? At the end of the day, it's like how we dispose files in the government office for payment, right? There would be a checklist that is put up that there are 6 items for which has to be complied with before payment can be done. And those 6 items are certified perhaps by 3 people, perhaps by 6 people. And finally, the file is put up for so-called approval of payment. That final approval of payment, if you look at it, is quite a redundant process. And if that can be triggered through what is called a digital escrow and the totality of which is called smart payment, then I believe that the process of payment and release of finances to the empaneled health providers can be expedited to a very large extent. With these words, I want to thank you for the kind invitation to talk to you, and I wish to congratulate the department and the new leadership of Parthasarathy Sen Sharma ji and Ravinder ji, and the extraordinary work and energy with which Sangeeta Singh ji has been stewarding this work in UP for the last so many years. Jai Hind.
Thank you so much, sir, for sharing your rich experience and way forward for the scheme. We shall certainly utilize your advice in the scheme implementation in the coming times. With that, I would like to invite Sri Devendra Khandayat ji, Deputy Director, Bill and Melinda Gates Foundation, to impart with a few words.
Thank you for this. Namaskar, and thank you Sangeeta ji for inviting, and thank you Himani and Manisha for following up. Adaraniya Parthasarathy sir, Ravinder sir, Director ma'am, and everybody on the dais, the NHA officials. मेरे सीनियर कलीग डॉक्टर संतोष मैथ्यू साहब ने ऑलरेडी he has put lot of he has suggested lot of very powerful ideas as always. So, and probably if I say it might be the repetition, so I will skip that part, and I am going to otherwise speak in the one of the plenary, so I will reserve that time. because Dr. Santosh Mathews is in Seattle and this is almost the midnight there. So I will be extremely brief so that there is a possibility of further interaction. I am looking forward to the inputs and the remarks from the PSS sir. So, but I just want to say one thing. This is the 4th year of the anniversary of the ambitious PMJ, which is a journey towards the universal health coverage. And thank you for the extraordinary leadership that is provided for this in a complex geography like Uttar Pradesh. So I just want to, on behalf of Gates Foundation, I would like to congratulate the government of UP and the Sachi's leadership for this commendable efforts. And हम जो डेवलपमेंटल सेक्टर में लोग हैं उनको थोड़ा सा ना हाफ ग्लास एम्प्टी देखने की आदत इतनी ज्यादा हो गई है कि हम हाफ ग्लास फुल देखना कभी कभी भूल ही जाते हैं. So, and that's why, and sometimes it is important that we take a pause and we see what is the progress that is being made. You look at NFHS surveys, you look at the SRS surveys. It was not very long time back that UP and Bihar were dragging the national averages. Very, very recent NFHS surveys, the UP is supporting the progress in India's progress in SDG goals. Very, very recently, and what is very special, I feel it's very special for the states, and I feel very, very humbled to be the part of this entire ecosystem, is the recent award for the facility registry during the Arogya Manthan to UP government and Sachis. And why it is very special? It is not a state gets awards, state will continue to get award. This is something called as whole of the government approach, because Google के drive पे जो which is available UP के स्वास्थ्य केंद्र app, which was developed for creating the dark spots in the infrastructure and the helping into the governance. Now that is capitalized for the PMJ, and take Abha ID and its potential. So then suddenly one is building on another and another is building on another. So this is the if we take the whole of the government and whole of the department approach, I think I always feel that this is the way forward, and I feel very, very proud of it. I just wanted to one more point about, because we are talking about the digital exploration and possibilities. The unitized digital data system which is created by the government of Uttar Pradesh during the COVID times, and many people say that I do have a conflict of interest, I work for the people of Uttar Pradesh and Bihar, but no, if I minimize and I may remove that conflict of interest, all the experts in the world say that this is not only the best in India, but it is probably the best in the world, the unitized data system developed for the COVID, which was for the seamless operations and actionable data between public and private, lab in the public sector, lab in the private sector, between the surveillance, between the surveys, between the facilities. I feel this is like, and now it has got the potential to take it to a enhanced disease surveillance system in its own way. So the limited point I want to say before I stop and before I make my other remarks in the plenary session is that the way forward in many of these things is whole of the government and whole of the department approach. And I feel that many of the work Sachi is leading is banking, and we should be collaborating on the basis of whether it is ANHM, whether it is self-help groups, whether it is Abha ID, and whether it is so many things. Once again, congratulations and thank you for the opportunity. Thank you.
Thank you for your kind words, sir. We certainly value our partnership with the prestigious Bill and Melinda Gates Foundation and shall look forward to taking the scheme to newer heights with your support. The principal focus of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the provision of hospitalization and treatment services free of cost to our singular most important stakeholder, which is our scheme's beneficiary. Documenting and journaling several beneficiary success stories of treatments under Ayushman Bharat has been compiled over the period of 4 years. Sanchis is pleased to announce the launch of our coffee table book on this auspicious day in the distinguished presence of our guests. I would request all the guests on the stage to kindly unveil our publication on the human stories of catalytic changes which could only happen because of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. तालियां नहीं बजती तो कुछ सूना भी लगता है और कुछ हल्का भी लगता है और कहीं लगता है कि मान सम्मान में थोड़ी कमी रह गई। बहुत मेहनत की गई है, 4 वर्ष ऐसे ही पूरे नहीं हुए हैं। इन 4 वर्षों में खून पसीना और बहुत सारी मेहनत लगी है। जितनी जोर से तालियां बजेंगी उतना ही सम्मान होगा सांचीज का, जिसने इम्प्लीमेंटेशन में महत्वपूर्ण योगदान दिया है, स्टेक होल्डर्स का, टेक्निकल सपोर्ट पार्टनर्स का और सबसे ज़्यादा उन 15 लाख लाभार्थियों का जिन्होंने इस योजना के माध्यम से स्वास्थ्य लाभ और कई केसेस में जीवन लाभ प्राप्त किया है। जोर से तालियां बजनी चाहिए। थैंक यू सो मच ऑनर्ड गेस्ट्स। इसी को आगे बढ़ाते हुए मैं बताना चाहूँगी, कोई भी स्कीम, कोई भी योजना जब सरकार चलाती है तो एक सोच और एक विजन के साथ चलाती है। वो विजन और वो सोच किस दूरी तक और कब तक और कहाँ कैसे पहुँचता है, इसको जानना बहुत ज़रूरी है। पिछले साल CEO सांचीज ने एक निर्णय लिया। उन्होंने कहा, मैं ये जानना चाहती हूँ कि मेरी स्कीम अपने लाभार्थियों तक यानी ज़मीनी स्तर के लोगों तक कितना पहुंच पाई है, कैसे पहुंच पाई है, क्या लाभ प्राप्त हो रहा है। जिस बड़े विजन को लेकर मोदी जी और माननीय योगी जी ने इस स्कीम को लॉन्च किया था, क्या उस स्कीम को उसी तरीके से लेकर हम फील्ड में पहुंच पा रहे हैं कि नहीं पहुंच पा रहे हैं, ये सब आगे बढ़ने से पहले जानना बहुत ज़रूरी था। और इसीलिए अब हम विमोचन करेंगे प्रोसेस इवैल्यूएशन रिपोर्ट का, जिसे IIT मद्रास और इरमा के सहयोग से एक्सेस हेल्थ इंटरनेशनल ने बनाने में मदद की है। ये प्रोसेस इवैल्यूएशन रिपोर्ट न केवल इस बात की सूचक है कि हमने 4 सालों में फील्ड में क्या किया है, बल्कि आगे आने वाले समय में योजना को किस तरीके से आगे बढ़ना चाहिए, इसको भी बताने में बहुत सहयोग दिया है। थैंक यू सो मच सर एंड मैम। एट द हार्ट ऑफ द स्कीम आर आवर बेनिफिशरीज for whom this elaborate scheme has been designed and is catered towards. Having battled impoverishment and disease, a few of our beneficiaries are present with us today who were given the gift of health protection by the scheme and whom Sanchis would like to felicitate today as Swasthya Amrit Jan-Samman. मैं अपने कुछ विशिष्ट बेनिफिशरीज को यहाँ मंच पर आमंत्रित करना चाहूँगी, जिन्हें हम सम्मानित करना चाहेंगे स्वास्थ्य अमृत जन सम्मान से। मैं निवेदन करना चाहूँगी प्रमुख सचिव सर से और CEO मैम से मंचासीन गेस्ट से शॉल और फ्रूट बास्केट देकर इनका स्वागत करें। ये जान लें कि ये सारे ही कैंसर पेशेंट्स हैं जिन्होंने योजना के अंतर्गत स्कीम का लाभ उठाया है। गुलाम वारिस जी, जो कि एक कैंसर सर्वाइवर हैं, गुलाम वारिस जी, इनका इलाज चरक हॉस्पिटल लखनऊ के द्वारा किया गया है। राकेश कुमार गुप्ता जी, ये भी एक कैंसर सर्वाइवर हैं। रामपति प्रजापति जी, श्री बाबूलाल जी, श्री बाबूलाल जी, मंतशा बानू जी। ऑडियंस की जानकारी के लिए बता दूं, ये सभी कैंसर पेशेंट्स और सर्वाइवर्स हैं। मंतशा बानू जी के बाद समीरा बानू जी। तालियां बजती रहेंगी, बहुत मान बढ़ेगा। ये सब हमारे लाभार्थी हैं जिन्होंने कैंसर पेशेंट में इलाज पाया है। विनोद जी, रामदीन जी, शारदा सिंह जी, प्रदीप कुमार जी, नवल किशोर जी, गंगादीन जी। तालियां बजाते रहिए, हमारे लाभार्थियों का मान सम्मान बढ़ाते रहिए। ये सब हमारे स्वास्थ्य अमृत जन सम्मान के योग्य पात्र हैं, कैंसर सर्वाइवर्स हैं। बहुत कम मौके मिलते हैं जहां हम ऐसे मंच पर अपने लाभार्थियों का, अपने जमीन से जुड़े स्टेक होल्डर्स का स्वागत कर पाते हैं। प्लीज तालियों की गड़गड़ाहट से इनका मान सम्मान बढ़ाइए। तालियां बजती रहनी चाहिए। आजादी के 75वें समारोह के नाम पे स्वास्थ्य अमृत जन सम्मान देने का निर्णय किया सांचीज ने इस बार अपने लाभार्थियों को, और ऑडियंस ये स्वास्थ्य अमृत जन सम्मान से ही सम्मानित कर रहे हैं हम अपने 12 कैंसर सर्वाइवर्स को। तालियां बजाते रहिए। यह एक बहुत ही महत्वपूर्ण लम्हा है हमारी चौथी वर्षगांठ पे, जहां हम अपने इतने गंभीर रोग से लड़ने वाले लाभार्थियों का स्वागत कर पा रहे हैं स्वास्थ्य अमृत जन सम्मान के माध्यम से। Thank you so much. Thank you so much, guests. At Sanchi's, we also applaud the success of our public hospitals in supporting Ayushman Bharat in its implementation and successful running. Today, we shall be honoring the effort and dedication shown by some of our public hospitals in being the top performing government hospitals in implementing the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. I would request the honored guests, please to honor them. The top 5 best performing government hospitals and institutions are King George Medical University, Lucknow. Dr. Balendra Pratap Singh ji can take the award. District Male Hospital, Banda. District Hospital, Amroha. We are very honored to announce the awards to Community Health Center, Hathi Bazar, Varanasi, and FRU Cholapur, Varanasi. Larger round of applause. No scheme is complete without the services, and public hospitals are one of the key components in the success of the scheme. स्वास्थ्य अमृत जन सम्मान से सम्मानित होने वाले हमारे पब्लिक अस्पतालों का मान बढ़ाइए, जोरदार तालियों से स्वागत कीजिए। CHC हाथी बाजार वाराणसी, FRU चोलापुर वाराणसी, दोनों दिलवा दो। तालियां बजती रहनी चाहिए। While Ayushman Bharat PMJ caters to a whole ambit of healthcare services, the focus for the 4th year of implementation has been strengthening cancer care services under PMJAY within Uttar Pradesh, as we've been mentioning since morning. In this regard, on behalf of Sanchi's, I would like to bring out top 5 best performing private providers in providing cancer care services under the PMJAY. Kindly bring upon Hanuman Prasad Podar, Cancer Hospital, Gorakhpur. I would request the district managers to please line up. Apex Hospital, Varanasi. Shri Ram Murthy Smarak Institute of Medical Sciences, Bareilly. Kesh Lata Hospital, Bareilly. And Dr. Sheila Sharma Memorial Charitable Hospital, Mathura. We would also like to honor Lucknow Cancer Institute for their spectacular work in providing cancer care services. And as a special category award, we would like to felicitate Rama Hospital, Azamgarh with the Swasthya Seva Samman. तालियां बजती रहनी चाहिए। जैसा कि हमने आपको बताया, चौथे साल में हमारा फोकस कैंसर केयर स्ट्रेंथनिंग पे रहा है। इसको हम कंटिन्यू करेंगे आगे भी। ये सारे वो अस्पताल हैं जिन्होंने गरीब बेनिफिशरीज को कैंसर केयर सर्विसेज प्रोवाइड करने में महत्वपूर्ण योगदान प्रदान किया है। There is a special category award for Aba Hospital, Azamgarh. ये स्वास्थ्य अमृत जन सम्मान से हम ऑनर कर रहे हैं अपने प्राइवेट हॉस्पिटल्स को, जिन्होंने कैंसर के क्षेत्र में महत्वपूर्ण योगदान प्रदान किया है आयुष्मान भारत प्रधानमंत्री जन आरोग्य योजना में। उत्साह बढ़ाइए, जितना इंपॉर्टेंट स्वास्थ्य लाभ लेना है उससे कहीं ज्यादा इंपॉर्टेंट क्वालिटेटिव स्वास्थ्य लाभ देना है, स्पेशली इन द फील्ड ऑफ कैंसर केयर। उत्साह बढ़ाते रहिए हमारे अस्पतालों का। लास्ट बट नॉट द लीस्ट, कोई भी स्कीम उसके इम्प्लीमेंटर्स के बिना कभी पूरी नहीं होती। एक बहुत ही ममतामयी गाइडेंस जो कि सीईओ संगीता सिंह मैम के द्वारा दी जाती है, टीम का भी एक बहुत महत्वपूर्ण योगदान है इस स्कीम को 4 सालों में यहां तक पहुंचाने के लिए जहां हम खड़े हैं। We would like to now felicitate some of the top performing district managers from Sanchis who have done wonderful work in the upcoming drive for card making, sir. I would like to call upon Ms. Neetu Singh, Operations Manager, to take the award from sir. Next is Ashutosh Johari, Shivam Gupta, Shatrughan Thakur and Anamika Tripathi. मैं आपको बता दूं, ये वो टीम है सांचीज की जो बांध कर रखती है लाभार्थियों को अस्पतालों से, अस्पतालों को सांचीज से और सांचीज को नेशनल हेल्थ अथॉरिटी से, ताकि एक सीमलेस स्कीम को रूप और आकार दिया जा सके। वो रूप और आकार देने में हम काफी हद तक सफल रहे हैं इन 4 सालों में, जिसमें इन लोगों का एक महत्वपूर्ण योगदान है। तालियां बजनी चाहिए, हमारा उत्साह कम नहीं होना चाहिए। जिनको अवार्ड नहीं मिला है उनके लिए ये एक प्रेरणा है अगले साल स्टेज पर आकर अवार्ड लेने के लिए। इकलौती महिला कैंडिडेट है, इसका तो जोरदार तालियों से स्वागत होना चाहिए। We are now nearing the end of our inaugural session, and now I would like to invite Shri Parth Sarthi Sen Sharma sir, Principal Secretary Medical Health and Family Welfare, to kindly grace the dais with his keynote address and guide us on the scheme's path ahead. Sir.
मंचासीन महानुभावगण और आयुष्मान भारत प्रधानमंत्री जन आरोग्य योजना के 4थी सालगिरह के उपलक्ष्य पे आयोजित इस कार्यक्रम में सम्मिलित सभी हमारे प्रतिभागीगण, सर्वप्रथम तो इस 4 साल के सालगिरह पे मैं सांचीज, उनके सभी लोग जो सांचीज में काम कर रहे हैं, उनके पार्टनर ऑर्गेनाइजेशंस, हमारे पब्लिक हॉस्पिटल्स, प्राइवेट हॉस्पिटल्स जो इस यात्रा में सम्मिलित रहे हैं 4 सालों में, उन सबको साधुवाद देता हूं और उन सबको मुबारकबाद देता हूं। That for 4 years relentlessly they have worked, and for a scheme which started from zero in 2018, we have come a long distance in this 4 years. But this 4 years is also a misnomer. ये 4 साल एक्चुअली 4 साल है नहीं, ये 4 साल 2.5 साल है, 2 साल है, क्योंकि बीच के 1.5-2 साल तो कोविड की वजह से ऑलमोस्ट 0 ईयर्स हो गए हैं। तो ये 4 साल नहीं माना जाना चाहिए, ये एक्चुअली उससे बहुत कम है। और उस इतने कम समय में कोई योजना को जो शून्य से शुरू हुई थी, उस योजना को इस लेवल तक ले जाना कि उसके सिस्टम्स बनाना, उसमें पार्टनर्स को इन्वॉल्व करना, उसमें इतने सारे 3000 से ज़्यादा हॉस्पिटल्स को इन्वॉल्व करना, हेल्थ पैकेजेस को बार बार डिफरेंट पैकेजेस को रोल आउट करना, और इसमें एनएचए का भी बहुत बड़ा योगदान है, क्योंकि द कंप्यूटर सिस्टम इज वन। तो सबके साथ मिलके करीब 2.5-3 साल के मौके पे हमने करीब 2 करोड़ 16 लाख लोगों को कार्ड डिस्ट्रीब्यूट किए हैं, अराउंड 88 लाख परिवारों को कम से कम एक कार्ड मिला हुआ है। करीब 15 लाख लोगों को चिकित्सा, आईपीडी की चिकित्सा दी गई है इन 4 साल में, और करीब 1300 करोड़ रुपए का खर्चा इसमें किया गया है। कई बार हम लोग अपने डे टू डे एक्टिविटीज़ में इतने ज़्यादा मशगूल हो जाते हैं, इतने ज़्यादा इन्वॉल्व हो जाते हैं, that we lose the big picture. Actually, it is a transformative scheme in both the scope of the scheme, a scheme in which the potential beneficiaries are 8 crores, 80 million people. 8 करोड़ की पॉपुलेशन तो कई देशों की, मतलब एटलीस्ट 100 कंट्रीज की पॉपुलेशन ही नहीं है 8 करोड़ की। So to have such a big beneficiary target और उस पर काम करना is both an opportunity and a challenge. A challenge because the scales are so huge, a challenge because not only the entire country but the entire globe will be looking at you, but it's also an opportunity to do great work. Sangeeta might be feeling a bit tired after 4 years. It is natural, it happens. But I would only like to emphasize to her and her team that the opportunity is also a global opportunity. आपको 4 साल में इतने लोगों की जिंदगी को छूने का मौका मिला है, 15 लाख लोगों की जिंदगी को छूने का मौका मिला है। और कई बार ये फिगर्स उसको कंसील कर जाती है जो हर एक की स्टोरी होती है। जब हमारे घर पे कोई बात आती है और हमारे किसी प्रियजन, our sister, our brother, our wife, our father, mother, they are admitted to a hospital, then we realize what one of this 15 lakh means. Each one of them is a human story. And our big figures, sometimes we lose this. और इसलिए I also want to congratulate her and her team for coming out with this storybook, the human storybook. Because each of these stories is a human story. This profession or this sector is a sector of empathy, something which we tend to lose in our day-to-day work. And it comes back to us when something happens in our own family. And then we realize what we are doing on this other hand. I would like only to re-emphasize that and get our motivation from that rather than from the figures. I would like to point out a few things here. हम लोगों ने बहुत कुछ किया है और आगे ये जो सालगिरह है ये एक मौका है जिसमें हम देख सके हमने क्या किया है और हम आगे क्या कर सकते हैं। हम लोगों ने फिगर्स देखे अपने, मैं दोहराना नहीं चाहूँगा, बट 2 crore 16 lakh cards, 3,000 empaneled hospitals, 15 lakh beneficiaries, 1,300 crores claims. Approximately these are the numbers. How does it compare to India's figure? मेरा मानना है कि हमारा फिगर उसका 1/5 तो होना ही चाहिए, बिकॉज 1/6 हमारी पॉपुलेशन है और गरीबी के हिसाब से देखेंगे, बैकवर्डनेस के हिसाब से देखेंगे तो 1/5 हमारा होना चाहिए। तो हाउ डज आवर फिगर्स कंपेयर टू पैन इंडिया फिगर्स? क्या हम उसमें 1/5 तक पहुंच रहे हैं? दैट शुड बी आवर बेंचमार्क, क्योंकि अदरवाइज हम कह सकते हैं कि 2 करोड़ 16 लाख हमने बहुत बनाया है, बट पूरे देश में अगर 15 करोड़ बने हैं तो हमारे पास 3 करोड़ होने चाहिए। सो दैट शुड बी आवर बेंचमार्क। सेकेंडली, कुछ चीजों पे जैसा कि बाकी लोगों ने भी कहा, क्वालिटी ऑफ केयर के बारे में, टाइमली पेमेंट के बारे में, यूज ऑफ डाटा के बारे में, सो दैट उस डाटा को देख के हम एसओपी से अंतर क्या है उसके बेसिस पे किस तरीके से पिन पॉइंटेड एजुकेशन दे सकते हैं, जो संतोष मैथ्यूज ने कहा। बेनिफिशियरी फैसिलिटेशन एजेंसी क्या हम पब्लिक हॉस्पिटल्स में एम्प्लॉय कर सकते हैं, कुछ स्टेट्स ने किया है। ग्रीन चैनल पेमेंट सिस्टम्स हम कर सकते हैं क्या, पब्लिक नहीं सिर्फ प्राइवेट हॉस्पिटल्स में भी क्या हम कर सकते हैं। पार्ट एम्पैनलमेंट हम हॉस्पिटल्स का कर सकते हैं, दिस इज फॉर एनएचए। हॉस्पिटल्स हो सकता है पूरा एम्पैनल ना होना चाहिए, हॉस्पिटल हो सकता है सिर्फ 4 चीजों के एम्पैनल होना चाहिए, क्योंकि वो 4 पैकेजेस उनको ठीक लगते हैं, उनका कैन वी डू दैट? सो देयर आर मेनी वेज, relentless we have to think and we have to go ahead. It is a day in which we can rightly and rightfully congratulate ourselves that we have done something. It is also a day to look at how more we can do. But at the end of the day, I would like Mr. I would like to thank Mr. Santosh Matthews, who has joined us from Seattle, which is almost midnight. I don't know whether he's still connected or not. We took your suggestion of a toll-free number center for all end-to-end health facility जो उन्होंने बताया. बिल एंड मेलिंडा गेट्स फाउंडेशन उनके पार्टनर ऑर्गेनाइजेशन के साथ हम लोगों का एक यूपी में बहुत लॉन्ग स्टैंडिंग कोलैबोरेशन रहा है. वी हैव एन MOU in which they provide us technical support. We are very thankful to that. So I throw the ball back to Santosh Matthews, sir, to design an RFP for this. Please put your best heads together and design an RFP for us for this toll center. We will find a way for the funds from somehow, but it can be really good if the RFP is very good. Then only you will get a good agency to run this center. If the qualification conditions, the payment module, the service level agreements, all are well defined. So I will like Devender Saab to look into this. Santosh Matthews, sir, is an old, very old connection. So I'm sure he will respect this need of ours. And this idea has come from him, so I'm sure that they will help us out. It can be actually be life-changing in the life of citizens. We talk about ease of business, we talk about ease of living. Ease of living, this is really the ease of living, if you can really do that. होता क्या है कि जब हमारे घर में आते हैं तो पहले हम सोचते हैं कि हमारा कौन कहाँ है कनेक्टेड, नहीं? So we find out कि PGI में हमारा कौन कनेक्टेड है. फिर सोचते हैं कि उसका PRO कौन है, उस PRO का फ़ोन नंबर नहीं तो डायरेक्टर जानते हैं तो उनको फ़ोन लगाएंगे. फिर हम कोई एम्बुलेंस ढूंढने निकलेंगे. और half of the reason why there is so much load on the tertiary sector is because of this, because the ये ईज ऑफ लिविंग क्योंकि नहीं है, लोगों को पहले कोई गाइड नहीं कर रहा है कि इसमें वहां तक जाने की जरूरत नहीं है, आपके यहीं से हो जाएगा. इसलिए सब के सब पीजीआई और केजीएमयू की ओपीडी की तरफ जा रहे हैं. सो आई थिंक इट कैन बी वेरी वेरी इंपॉर्टेंट. लेट अस टेक इट फॉरवर्ड. एंड माय एक्सपीरियंस इज दैट इट स्टार्ट्स फ्रॉम द आरएफपी एक्चुअली. उसमें फिर हम करते रहेंगे एक्सरसाइज की, उसमें कैसे आगे बढ़ेंगे. बिकॉज दिस काइंड ऑफ वर्क के लिए ऑनबोर्ड करने की भी एक टेक्निकल रिक्वायरमेंट्स और टेक्निकल कैपेसिटी है, और वो हम सबके पास नहीं होती है. द एडवांटेज ऑफ ऑर्गेनाइजेशंस लाइक बिल एंड मेलिंडा गेट्स फाउंडेशन एंड अदर्स आर देयर पार्टनर ऑर्गेनाइजेशन आर दैट दे हैव ए ग्लोबल एक्सपीरियंस. तो अपने बैक रूम में जाके वो देख सकते हैं कि इस टाइप की चीज़ बाकी दुनिया में कई जगह हो चुकी है जो हमारे लिए मुश्किल है, बट उसको फिर ट्वीक भी करना पड़ेगा यूपी के सिचुएशन को देखते हुए. यू कैन नॉट जस्ट कट एंड पेस्ट दैट आरएफपी. मैं इतना कुछ बोलना नहीं चाहता था. दिस इज एन ओकेशन फॉर मी टू लिसन. आई हैव जस्ट जॉइन्ड दिस डिपार्टमेंट. आई विल बी ओपन टू योर सजेशंस. आई थिंक वी शुड ऑल्सो डू ए डिप टेस्ट ऑफ अराउंड 100 प्राइवेट हॉस्पिटल्स रैंडम, कि वहाँ उनको क्या समस्या आ रही है, नहीं आ रही है, प्रोसेस पेमेंट में क्या समस्या आ रही है, रेट्स में क्या समस्या आ रही है, क्या नए रेट्स में के बाद भी आ रही है, एम्पैनलमेंट जो मैं कह रहा था, पार्शियल एम्पैनलमेंट, क्या ये हो सकता है. लेट अस डू ए डिप टेस्ट ऑफ 100 थ्रू बिल एंड मेलिंडा गेट्स फाउंडेशन, 100 रैंडम प्राइवेट हॉस्पिटल्स टू फाइंड आउट क्या हो रहा है. I also congratulate Sangeeta and her team for launching this process evaluation report जो IIT Madras के साथ उन्होंने किया है. I will definitely go through it. This is very important for us to understand कि हमारे processes क्या हैं, उनमें और क्या सुधार की आवश्यकता है, उसमें क्या कमी है. Because जब तक हम उसको नहीं देखेंगे तब तक हम अपने आप को कभी सुधार नहीं पाएंगे. So it is a very very good step that a concurrent process evaluation has been done. I only take this opportunity to congratulate you all once again for embarking and for being in this journey, and I just hope that you do not get tired. Thanks.
Thank you so much for encouraging words and sound advice, sir. I think we've got the roadmap for the next year, which is ease of living. So the entire focus now this year, the 5th year, would be on ease of living, and I hope that on the next anniversary celebration, we would have something to share with the August gathering on achievement towards making life easier for our beneficiaries. And I'm sure that in your guiding presence, the scheme in Uttar Pradesh would scale greater heights of achievement and triumph in providing health assurance to every single vulnerable beneficiaries in Uttar Pradesh, sir. With that, I would like to invite Dr. Rajendra Kumar, the GM Operations, to kindly close this session with a vote of thanks.
आदरणीय प्रमुख सचिव महोदय, बिल क्लिंटन फाउंडेशन से हमारे आए सम्मानित प्रतिनिधि, हमारे विभाग के महानिदेशक महोदय, आरएमएल के प्रतिनिधि एवं समस्त इस कार्यक्रम में प्रतिभाग करने वाले प्राइवेट राजकीय चिकित्सालयों के प्रतिनिधि, जीआईजेड के सहभागी, प्लस हमारे एक्सेस हेल्थ इंटरनेशनल्स के प्रतिनिधि, मैं आप सबों को धन्यवाद ज्ञापित करता हूं। खासकर इस विशेष ओकेज़न में, यद्यपि हम लोग 4 वर्ष के अवसर पर, इस कार्यक्रम के 4 वर्ष के अवसर पर इसका आयोजन कर रहे हैं, इस उम्र में मैं ये बताना चाहूँगा कि हर आदमी सोशल मीडिया का बड़ा शौकीन हो गया है, हर के हाथ में, चाहे वो बालक हो, युवा हो, और हमारे जैसे शायद सीनियर सिटीजन भी, हाथ में मोबाइल और मोबाइल में सोशल मीडिया। मैं इन बातों को इसलिए कह रहा हूँ कि इस सोशल मीडिया एक बहुत बड़ा प्लेटफॉर्म दिया है, एक गैदरिंग का। बहुत सारे हमारे पास एडवाइसेस आते हैं सोशल मीडिया के द्वारा, हम लोग अपने अनुभवों को भी शेयर करते हैं अपने सीनियर्स के साथ में, एनएचए के साथ में। तो उन सबों को भी मैं धन्यवाद ज्ञापित करता हूं जो हम लोगों को ज्ञान वर्धन देते हैं, दिग्दर्शन दे रहे हैं। मैं यहाँ जस्ट धन्यवाद सिर्फ इसलिए नहीं कि उनका प्रेजेंस है, धन्यवाद इसलिए कि बहुत सारी चीज़ें जो शायद हम लोगों के कंसेप्शन में नहीं था, हमारे सर प्रमुख सचिव महोदय, हमारे दूर से बैठे हुए अन्य प्रतिनिधि जी ने बताया है, डाइवर्सिफिकेशन ऑफ जो हेल्थ सर्विसेज होना चाहिए, क्वालिटी केयर, ये हमारा अगला मुद्दा होना चाहिए। और मैडम ने कहा कि फ्रॉड को हम लोग कैसे कंटेन करें। मैम, मेरा मानना है कि नथिंग इज़ इम्पॉसिबल। बचपन से मैंने यही पढ़ा है, जो आज शायद इम्पॉसिबल दिखता है, कल वो पॉसिबिलिटी के लिस्ट में होता है। तो मैं ऑन बिहाफ ऑफ सांची और सांचीज़ के तरफ से, समस्त स्टाफ की तरफ से, ये मैं आप सबों को यह बताना चाहता हूँ, शायद कंफर्म करना चाहता हूँ कि सब कुछ संभव है। हम लोग आप लोगों के मार्गदर्शन से आगे बढ़ेंगे। और जो 4 साल में पाए हैं, सर ने बताया कि शायद 2.5 साल की, शायद क्या वास्तव में 2.5 साल की उपलब्धि है, तो निश्चित रूप से आगे बढ़ेंगे। आप सब आए सर, हम लोगों को मार्गदर्शन दिए, भावनाओं से, शब्दों से, एडवाइसेस से, एक्सपीरियंसेस से। वंस अगेन थैंक्स सर, थैंक्स आप सबों को, थैंक्स।
चूँकि ये कार्यक्रम जन सम्मान का है, रिक्वेस्ट करूंगी संगीता मैम से कि ये जन सम्मान को आगे बढ़ाते हुए फेलिसिटेट करें हमारे पैनलिस्ट्स को। सबसे पहला सम्मान प्रमुख सचिव सर को मैम की तरफ से। रविंद्र सर के लिए मैम की तरफ से। डॉक्टर सुधा, एनएचए। श्री देवेंद्र खंडायत जी, डेप्यूटी डायरेक्टर बिल एंड मेलिंडा गेट्स फाउंडेशन। श्रीमती रेणु वर्मा मैम, डीजी फैमिली वेलफेयर। एंड डॉक्टर बालेंद्र प्रताप सिंह, KGMU। समय पर रहना एक अच्छी आदत होती है। इसी के साथ धन्यवाद करना चाहेंगे सारे पैनलिस्ट का जिन्होंने इनॉग्रल प्लेनरी में हमारा सम्मान बढ़ाया। एक छोटा सा टी ब्रेक है, निवेदन करना चाहूँगी कि अगर 10 मिनट में सभी लोग वापस आ सकें चाय लेकर, चाय के साथ, तो हम टेक्निकल सेशंस अपने स्टार्ट करना चाहेंगे। 2 बहुत ही महत्वपूर्ण टेक्निकल सेशंस का आयोजन किया है हमने, जिसमें से पहला है इम्प्लीमेंटेशन, नेक्स्ट जनरेशन इम्प्लीमेंटेशन ऑफ द स्कीम, जहां इस इवैल्यूएशन रिपोर्ट के बारे में भी थोड़ी और डिटेल में चर्चा की जाएगी। रिक्वेस्ट करूँगी सभी गेस्ट से कि कृपया जल्दी से जल्दी चाय लेकर वापस आएँ ताकि हम सेशन को आगे बढ़ा सकें। थैंक यू सो मच. Thank you all the honored guests on the stage. VIP. हेलो 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 रॉन्ग नंबर
सभी से निवेदन है कि प्लीज़ अपनी अपनी सीट्स ले लें, हम लोग सेशन शुरू करेंगे. I will also request the panelists for the session to please come on the dais. Dr. Sudha Shankar, Dr. Umakant, Gomti, Dr. Devendra. गुड आफ्टरनून एवरीवन. मेरा नाम हिमानी है और मैं एक्सेस हेल्थ से हूँ. एक्सेस हेल्थ का ये बहुत बड़ा सौभाग्य है कि हम सांची के साथ पिछले 4 सालों से जुड़े, जिसमें पीएमजे इम्प्लीमेंटेशन में हम जो भी सहयोग दे सके हमने दिया है. ये हमारे लिए एक बहुत बड़ी अपॉर्चुनिटी है एंड आई एम इक्वली वेरी वेरी प्राउड टू होस्ट दिस सेशन. हम लोग आज 4 साल पीएमजे इम्प्लीमेंटेशन के मना रहे हैं और किसी भी बड़े रिफॉर्म की एक जर्नी बहुत लंबी होती है. आप लोगों में से कुछ लोग आरोग्य मंथन जो एनएचए ने इस वीक में ऑर्गेनाइज करा, पार्टिसिपेट किया होगा. और हमने बहुत सारी कंट्रीज़ के रिफॉर्म्स के बारे में जाना जो 20-25 साल लगे उनको उसको एक लेवल पे पहुंचाने के लिए. तो हम लोग अभी 4 साल हम लोगों ने कंप्लीट किए हैं, जो एक अर्ली इम्प्लीमेंटेशन फेज़ है पीएमजे का. और पर इसका काफ़ी एक्सपीरियंस बोथ एडमिनिस्ट्रेटिव, ऑपरेशनल, टेक्निकल हमारे पास है. और ऑब्जेक्टिव ये है कि इन सब चीज़ों को लेके हम आगे आने वाले 3-4 साल कैसे प्लान करें. सो ये हमारा ऑब्जेक्टिव है. अगेन जैसे सर ने भी कहा, सांची की ये लीडरशिप थी कि उन्होंने एक कॉन्करेंट इवैल्यूएशन को इतना महत्व दिया. और हमारे साथ भारत की 2 प्रीमियर इंस्टीट्यूशंस आईआईटी मद्रास और इरमा हैं जिन्होंने इस रिसर्च पे हमारे साथ काम किया. रिसर्च के अलावा हम लोगों ने एक हाउस होल्ड सर्वे किया है जिसमें 4000 हाउस होल्ड बेनिफिशरीज़ के साथ बातचीत हुई. उनका फीडबैक लिया गया है जो कि बहुत क्रिटिकल है, क्योंकि फाइनली उस बेनिफिशरी को इस स्कीम से क्या बेनिफिट मिल रहा है, उसका क्या एक्सपीरियंस है, वो सबसे ज़्यादा इम्पॉर्टेंट है. और ये हमारे लिए भी बहुत इम्पॉर्टेंट है कि हमारा काम आगे कैसे चल रहा है. सो जैसा सेशन का टाइटल है, हम लोग पहले थोड़ा समय डॉक्टर उमाकांत के साथ फाइंडिंग्स सुनेंगे और उसके बाद वी हैव अ पैनल. बट बिफोर दैट आई थिंक आई विल टेक सम टाइम टू इंट्रोड्यूस अ वेरी वेरी इलस्ट्रियस पैनल दैट वी हैव. पीएस सर से सब मुलाकात कर चुके हैं, लेकिन मैं थोड़ा सा उनके बारे में बताना चाहूँगी. उनका एडमिनिस्ट्रेटिव एक्सपीरियंस काफ़ी है, लेकिन आई डोंट नो हाउ मेनी ऑफ अस नो दैट वन ही इज़ a very popular author. So beyond doing just administration, he's also written a lot of fiction and non-fiction books. Plus in 2019, he was part of the coveted list of the most top 50 effective bureaucrats. And we are very, very happy that we have got his leadership in a very crucial time when we move from early implementation to mid implementation. So we're very happy he's there with us and on this panel. I would like to introduce Dr. Umakant Dash, who heads IRMA, Institute of Rural Management, Anand. And he spent, of course, decades doing research. इससे पहले वो IIT मद्रास में प्रोफेसर और HOD थे. अभी भी वो इंडियन इंस्टीट्यूट ऑफ मैनेजमेंट में एडजंक्ट प्रोफेसर हैं और काफ़ी सारी भारत सरकार की कमिटीज़ हैं जिन पे वो मेंबर हैं. सो थैंक यू सो मच डॉक्टर उमाकांत फॉर जॉइनिंग अस. Dr. Sudha Chandrasekhar is an Executive Director, Hospital Policy and Hospital Management at the National Health Authority. She herself is a medical doctor, public health specialist and a pharmaco-economist. पिछले 24-25 साल से वो इस फील्ड में काम कर रही हैं और एक्चुअली एनएचए में बहुत इम्पॉर्टेंट रोल प्ले करती हैं, क्योंकि हम लोग सप्लाई के बारे में बात करें तो किस तरीके से एक बेटर हॉस्पिटल नेटवर्क हम लोग क्रिएट कर सकें. सो हर रोल इज़ टू हेल्प द स्टेट्स क्रिएट दैट नेटवर्क. वी आर ऑल्सो वेरी हैप्पी टू हैव गोमती वेंकटचलम, who heads financial inclusion and insurance at Karkinos Healthcare. And she has 2 decades of experience in insurance, broking, reinsurance and telecom. प्राइवेट सेक्टर में इंश्योरेंस में इन्होंने काफ़ी समय बिताया है और अभी इनका पैशन है मैनेज केयर स्पेस में काम कर रही हैं. और कार्किनोस में she's working on developing a holistic preventive care solution which is affordable, especially for that segment of a population जो अभी insurance में covered नहीं है, जिनको हम लोग missing middle के की category में अब ला रहे हैं, तो जो बहुत गरीब हैं वो स्कीम्स में कवर्ड हो जाते हैं कुछ प्राइवेट इंश्योरेंस में, बट एक बहुत बड़ा 40-45% हमारा पॉपुलेशन बेस है जिसके पास इंश्योरेंस नहीं है. सो शी वर्क्स ऑन दैट. Thanks for joining us. Of course, Dr. Devendra Khandai doesn't need an introduction. He's been a champion of health system strengthening in UP, and he spent a lot of time here. He focuses on areas of health, supply chain, quality of care. He is also a medical doctor and a trained public health professional. He's a person who thrives being with the communities, and अपने पूरी लाइफ में इन्होंने 175 ज़िलों में काम किया है और रहे हैं, और इसके अलावा ग्राउंड के साथ इन्होंने बहुत सारी इंटरनेशनल और नेशनल ऑर्गेनाइजेशंस के साथ भी काम किया है. सो ये छोटा सा इंट्रोडक्शन है. वी विल मूव टू द सेशन एंड आई विल रिक्वेस्ट डॉक्टर उमाकांत टू टेक अस थ्रू द फाइंडिंग्स, एंड उसके बाद हम लोग डिस्कशन शुरू करेंगे. डॉक्टर उमाकांत.
Very good afternoon, esteemed members on the dais and off the dais. At the outset, I would like to congratulate Sangeeta Madam for successfully completing 4 years, and the data that she presented in the inauguration speaks volume. So again, as one of my colleagues told, always we as researchers see the half glass. The half glass which is empty, it's not necessarily always we have to. So sometimes, of course, we become critical, but definitely the half will also makes a lot of sense. And we derive a lot of inspiration, and the way it is moving, and the trajectory that we are going to take, everything depends on how much we achieved, be it 2 years, be it 4 years, be it 10 or 15 years. So I must thank Access Health for giving this opportunity to undertake this particular project. We have done before studying UP, we did for Tamil Nadu, we did for Bihar, and we did for Haryana. So always our dream was to come to a state like Uttar Pradesh so that we can go closer to the scheme, and what are the challenges we are confronting be it implementation or be it conceptualization, and learn from each other. So it's not that each state is unique. What works in Tamil Nadu might not work in Haryana, or what worked in Haryana might not work in UP. So it's our effort was to bring the experiences of these 4 states so that we can talk about the systemic problems, we can talk about the micro problems, and we can talk about the problems that we face in the entire value chain. So initially when we started, we did the claims analysis for a couple of years in the initial 1920. And that was, of course, a feeder for selecting couple of districts, because it was not possible to do a household survey for the entire state. Using the claims data, using the utilization statistics, secondary data that those are available, we narrowed down to a couple of districts, so which I'm going to, so who is going to cooperate? Yeah. So the objective of, again, this particular research was to take stock of the early implementation problems, identify challenges, draw lessons, and make sort of medium-term policy recommendations to SACHI and to the government of Uttar Pradesh, which are going to be in a manner help achieving the objective of this particular scheme. The objective is how quickly more people are going to get benefited from that particular scheme. So we tried studying the different issues. We have analyzed the study of efficiency of government structure, what kind of structure is there in SACHI, whether it is in line with what is being recommended by the NHA. whether the management process and monitoring mechanisms are in place, and whether they are effectively, say, undertaking what they are supposed to do. We also study early implementation processes. Again, there will be teething issues which we also encountered and we've observed in Bihar, we observed in Haryana. The same was the case in Tamil Nadu. Tamil Nadu, of course, was slightly different because they started this particular scheme, the Chief Minister's scheme, which was there, and they just scaled it up to Pradhan Mantri scheme, which was almost 10, 12 years old. So the method that we adapted here, so in order to understand the programmatic or the key information, the methods that we use is initially we have done desk reviews where we have taken the secondary data that is available, the manuals that are available, the guidelines that are available with the SACHI and with the NHA. And we also undertook key informant interviews. We have, as I told, we have selected 10 districts, but we couldn't able to make to 10 districts because of COVID. So we could able to visit 5 districts, interacted with DIUs, private hospitals, public hospitals, and other implementing agencies as well. And the third part of this particular study was we have undertaken a household survey because we need to understand the supply as well as the demand side issues. What is the level of, say, knowledge or awareness about this particular program, what they find good, convenient about the program, whether they know the facilities that are being available under this particular scheme, and how satisfied, comfortable they are, whether the informations are available, which are the empaneled hospitals, what kind of treatments they can avail under these schemes. So we had a comprehensive questionnaire which we implemented, which we administered to households selected from these 10 districts. From each district we selected 400 households, which covers those who enrolled or who has the cards, and those who are enrolled but use and enrolled did not use, and those who have not yet enrolled or didn't have the card. So close to 40% of them, they have yet to be enrolled or to get the golden cards. So that it is going to give a perspective which covers the entire, say, population. So these are the districts that we have taken, which is going to again take care of all the diversities. Better performing district and relatively not that better performing districts. So we have taken Meerut and Aligarh. We have taken Bareilly, Philway, Unnao, Bhadoi, Fatehpur, Jhansi, and Varanasi, Siddharth Nagar. We have visited to 5 of the Siddharth Nagar, Varanasi. We have gone to Unnao, Meerut, Aligarh. So which is more or less the experiences are same. I must here say again congratulate CEO Sachi for the way they have deployed the people. Wherever we have gone, the one thing which we have observed and appreciated, the committed people, the DIUs, the district officials, could be because they belong to that particular district, or whatever be the reason, that level of commitment is very high. I think if they maintain or work in the same manner, these statistics are going to double in no time. So that much guarantee we can, at least I'm convinced. The second thing, of course, there are systemic issues which NHA and other states, they are trying to address, particularly as far as the SECC database that was being used. A lot of challenges when we are, because it is not syncing with the beneficiary. A lot of beneficiaries have moved to other places. They are not staying, and when the SECC was prepared, that most of the beneficiaries, they were kids, they were known by the nicknames. The Manu became Manorama, and Sanu became something else. So when the time comes to go to the hospital and avail the facilities, they are not able to get the card because it is not matching with their ID cards now. So there are, of course, challenges which any particular scheme will have. So there's nothing new with this particular scheme, but how to navigate and what kind of arrangements we can make so that people are going to access, people are going to get the benefit without, with the least cost and least stress, I would say. Cost, why? Because when they move from one hospital to other hospitals and the time of, when they need the service, they are being turned down. They say you're not a member and that. So those kind of stories which we ourselves has witnessed, and we got to know from the private providers, and we got to know even the officials. I think somewhere there the NHA and the state can think of how can we empower the district magistrates or local people or some authority whose letter can be at least respected and could be used to in order to add the beneficiaries to the list. The second challenge, again, which was touched upon, of course, my panelists, they are going to definitely debate or discuss is about the type of quality and perception, which again, I will summarize half of the things which were already discussed in the inaugural session, so we can skip those. We can go to the major findings. Next, please. I think when we talk about the governance structure in place, you will see that again, something which is commendable is the SACHI could able to adapt the processes and the committees which are recommended or at par with the NHA. So from time to time, they have constituted the committees, be it anti-fraud unit or be it the grievance committee. So more or less, they are in line with what is being prescribed or suggested by the NHA. Somewhere, of course, even as recent as August 2021, they constituted rapid response team for redressing the grievances which they are receiving from the beneficiaries. As much as possible, of course, the major challenge again, which we have been seeing for the last 3 years, now of course it has reached a good number, otherwise the HR was one of the major problem. I think now it is close to where the sanction strength is 40 plus, we could able to see 34, 35 members are there in the team. So because the bigger the member and bigger the team, the better is going to be the implementation, and easier is going to be the implementation. And next, please. Next slide. So these are some of the things which, of course, was discussed, and I will not touch upon because these are the data which was which everybody know and talks volume. So what we are going to do, I'll just take you to the household survey, which will tell the perception of the beneficiaries and the level of satisfaction, the kind of information that is available with them. Next. Yeah, so as I told you, so this we have covered close to 4,000 plus households. Almost rural urban is 60-40, and the male-female gender the difference, if you see, it's 53% male and 49% is female. So as much as possible, we try to maintain the population dimensions, and it should be representative of the entire beneficiaries. The monthly income of these households, what we gathered from through the questionnaire is approximately 10,418, which is again more or less the average. And 56% is they are till 10th, 13% is some exposure to college. That's the, so you can, why we are saying we can see at the level of aspiration. We have to, while interpreting the data, we have to keep all this as the control variables. And preferences, of course, as was again pointed out, that there is, could be because of perception. Again, that's something which we have to analyze, which we have to discuss and debate, whether that perception is, to what extent the perception is the reality. But the experience that we have from Tamil Nadu, it is not that the private facilities are in any way better than the public facility, but that's the perception. We feel the quality being offered in the public domain or public hospitals are relatively, that's a perception. I think that's the responsibility of people like us, the administrators and other stakeholders to bring as much clarity as possible. Financing, 60% is depend on borrowing and loan, and distance more often they are traveling, so because most of the empaneled hospitals would be in the district headquarters, so therefore you would see on an average they are traveling, 48% is travel more than 10 kilometers, 30% is travel more than 21 kilometers Next, please. The level of awareness, again, when we see the level of awareness, yes, that's a good thing. Again, 86%, 87% of the households, they are aware of the PMJAY and MANJA. They know that this scheme is a cashless scheme and they are entitled to. So that's the information, at least the good thing that majority of our beneficiaries are aware of. But when it comes to the features, the helplines, the system of grievance redressals, place to enroll, there is some amount of, information is not available to them. But more or less, if we compare 80% is not, anything around 80% is definitely, it's a good number, given the number of years the program was initiated. Next, please. Again, features of this scheme, be it the coverage or be it the nature of whether it is cashless or you have to make payment or reimbursement, whether the length of stay and the family coverage, whether you can add beneficiaries to your existing list. So those are the features we probed while administering the questionnaire, so that then we would be double sure that people know what it is. And portability, as was again we were discussing in the morning session, 9% of our beneficiaries, they could able to use the services availed in other states. So that is what we were questioning. I think more or less, except the length of stay and family coverage, the information's majority, 70-75% they are aware of the features. It's again because of the various instruments which are being adopted by the government and other agencies. Next, please. Here that is something which definitely we, as policymakers we need to worry about, is the EHCPs or the empaneled hospital, the providers, which are the providers, whether they have the information, because unless you go to the hospital, you will only in the hospital you will see the board. So unless they go to the hospital, they do not, otherwise you have to call helpline and find out whether a particular hospital is available or not. So when somebody is in distress or when somebody is met with an accident, it's very difficult to expect somebody to make a phone call and find out, or family members. And some people might not have the phones as well. The penetration, of course, is increasing, but it is again difficult to expect that everybody is going to be equally literate and can comfortably use these phones. So majority of them, they are confused where to go. They get to know only when they go to the hospitals. So some kind of, I think even which was earlier practiced in Tamil Nadu, which they also discontinued initially, when at the time of enrollment they were giving a booklet which comprises the list of the hospitals. Of course the list of hospitals will keep changing, but at least it is going to give a sense in my district how many hospitals are listed. It may cost us, but that is kind of some kind of information which will help the beneficiaries while accessing. And it so happened, some of the people, they sought the service because they did not know that this particular hospital is an empaneled hospitals, or the Arogya Mitra, the person who did not clarify, they had to pay and get the treatment. So these are kind of couple of experiences which we could able to gather when we visited households and talked to people. This is about, again, the awareness on disease cover. It's 40-45%, because they are not sure of what are the packages is administered. We know, but are they? That's a big challenge. Unless they are aware of and unless they know what kind of treatment, what kind of packages or diseases or ailments are covered, sometimes they miss out, or sometimes they don't seek care, because in India, again, a lot of people, they keep quiet unless it is very urgent. They don't seek care, which they could have. If they are aware of, if they know, some of them they could have availed, and instead of waiting till the last moment, it becomes very complicated cases, they could have sought the care. Next, please. Post-hospitalization benefit, how many of them they're aware of the post-hospitalization? Again, it's not very high, 50% is not bad, again, given the 2.5 years, 3 years. But I think somewhere we have to make them more aware so that the utilization uptake is going to be better. and the impoverishment effect is going to be lesser. Because again, the out-of-pocket expenditure or the impoverishment effect in case of the health expenditure, the literature tells the figures are very high. Next, please. Awareness about the mechanism of grievance redressals. So this is broadly, again, 60-65% they are aware of the redressal mechanisms, and they also made use of. It's not that just they're aware of, and many of them they have utilized or used the services whenever they found something lacking or they don't have the information. They quickly dialed and send the grievances, and again the grievances are timely addressed. Many of the time it is being addressed on time. So there, most of them you will see when it comes to the satisfaction, it will tell again the true picture. They are very happy about whatever they are getting. They are relatively happier. Next, please. Satisfaction with the helpline. You can see it 75 to 80% they are happy with the way it is being addressed. So be it about information about the enrollment, or information about the empanelment hospitals, or information about the kind of disease or ailments, whether it is covered or not, more or less it is being addressed. Satisfaction with the scheme is, I would say, pretty high, because again, as I told you, the aspiration could be, they are not highly aspired, the aspiration level could be very low, but as we go along, as they get more and more information, the aspiration will be higher and higher, and they would demand better quality services. But at this point of time, you would see 90% is close, 95% is people are those who use, they are satisfied, because at least it is helping them. So that way, definitely, I would say the scheme is delivering what it is supposed to. But the rate at which we are going to make changes, bring changes, and increase the uptake, that is what is more challenge. Ease of difficulty in enrollment, people found they're very easy. Because again here, I would raise somewhere, of course, we try to centralize, because sometimes because of the centralization, there were a lot of challenges, which also we got to know when we have visited the district offices. Somewhere I think, again, as was practiced, we have to a sort of interdepartmental coordination. That's where the interdepartmental coordination is going to help a lot. Suppose if we involve the Panchayat Raj and RD departments or other departments in enrolling them at a faster rate, and making the cards available to them so that they know this is the card which they are going to use. Many of them, they have not yet received the cards. It was lying somewhere else. So as per the statistic, it is enrolled, but they do not have the card because the information that is there on the card is not sufficient enough to deliver the card back to the villages or the households. And the medical officers and the DIUs, they're struggling to distribute the cards. Hospitalization experience, again, you'd see how in 3 years utilization distributions enrolled and availed, 60% people they have, and those who enrolled, they have availed. So that's again a good sign. Only 12% who enrolled and did not avail. I think that could be because of many other factors which we did not probe, but I think that number is not very high. But non-enrolled and not avail is again 28%. Next, please. Next. And this is something again which we want to. So whatever information we collected from through the household survey, average expenditure is out-of-pocket expenditure is coming around, those who have gone to the private hospitals, around 18,000 is the out-of-pocket expenditure, and those who have gone to the public, it is 7,523. Here again you can see to what extent the households they save money. It's not how much they spent, because if you take on an average 28,000 is what they spent on hospitals, or if you take on an average those who did not enroll, they have spent 28,000 on an average. And if we take the number of cases they have utilized and the total amount we spent, it comes around 12,000 to 30,000. So 28 minus 12, 13, it comes around 16 only. So it is, so to that extent it has reduced the out-of-pocket burden. But the only thing we have to see is how we are going to fill the gaps where the challenges are, because we have to enable and see the difficulties, why and how these, of course, the out-of-pocket, it is very difficult for any system, even in a developed system, the out-of-pocket is going to be there. We cannot make the out-of-pocket expenditure zero. Similarly, grievance can't be zero. If the grievance is zero, then something is wrong. So grievance has to be there so that the system is going to, improve. That's a trajectory which we are going to take. The only thing is we have to analyze, interpret, and take corrective actions so that over the years, the number is going to be lesser and minimum. Next, please. Beneficiaries who could use PMJY reduced. This is what I was talking about, to what extent it has reduced their burden. Significantly, you will see there are households who otherwise would have gone below poverty line. It saved them. How many people, how many households we could able to save or we could able to touch, that is more important. As we go along, I think this is going to improve and will be much better. Next, please. Areas for consideration again, next. Yeah. So these are some of the things which were emerging from the KIIs and the survey that we have undertaken, which could be, we can say, beneficiary empowerment and what can be thought of in order to strengthening the supply side or minimizing the supply side constraint or the issues. The third is how are we going to strengthen the administration so that more and more people are going to get benefited, they are going to enroll, and the program is going to be a success. When we talk about some of the supply, again, the hospital, we are expanding at a faster rate. But again, the major problem, if you take some of the district, there are not many private hospitals. So when there are not private hospitals, how are the system can't enroll or impanel them. So there are, you will see, it's not at all because of the administration, but these are because of the systemic issues. Quality of care, again, that I'm sure will be delivered. At a lot of the time, it could be perception. Could be sometime it is because of perception, could be sometimes because of the real quality issues. So we have to again probe further and see what that the system can do in order to minimize improve the quality. So when it comes to strengthening administration, again it was pointed out the timely payment of the hospitals. Suppose if it is, because that is what is going to attract more private hospitals into the net, and they will have, if it is efficiently managed and smoothly transferred, that is going to even motivate them to treat treat as many patients as possible. Because always they say, what is the difference between the private player and this, say, PMJY? In private insurance, we get it done smoothly. And why it takes so much of time when it comes to PMJY? So I think these are some of the questions. So again, I appreciate when Secretary Sir told that we are going to do a deep dive to find out, call 100 hospitals to find out what are the concerns. I'm sure with this kind of efforts, the efficiency level and effectiveness is going to definitely improve. And somewhere we have to also be responsive because sometimes it's not just offering the services, but how we are treating them. That is more important. So these are a couple of, when it comes to beneficiary empowerment, transportation spending, geographical access, setting up a mechanism to collect regular patient feedbacks. So these feedbacks, not only just collecting the feedback, but how that is going to be analyzed and incorporated for doing the mid-course corrections. So these are some of the things which I thought I would propose, and so that some discussion will happen around these points. Once again, I would like to thank Sakshi and Access Health for this opportunity, and we would definitely be happy to be part of this particular exercise and can contribute in any manner for the betterment of the society. Thank you very much.
So, sir, if there are questions, we can open for some questions on the research. Otherwise, Okay, maybe we can take 5 minutes to take any questions. अगर कोई questions हैं evaluation को लेके तो अभी हम ले सकते हैं and then we will move for the discussion. So, sir, is this question on the research या आप PM? Okay. Do you want to take?
I think when we have, this is based on, if you ask me on based on this particular household survey and the research that we have undertaken, so when we have gone to the households, basically the house questionnaire was administered to the head of the households, and it was for the year, right? So, and how much of the ailment that we are talking about, be it 14% of the, generally, as I think the morning the secretary was also telling, we should take the life cycle of a person. In the young age we are jumping, and when it comes from the mountain, if you take the example of the river. So could be because when it comes to the hospitalization, etc., how many of them are getting hospitalized, whether those are there in the package or not, that we need to discuss. But we have not done like how, say, age versus utilization. I think if we do the age versus utilization, it might not be close to 14%, but I think some of the say utilization or the diseases are covered, and they have, of course, utilized.
Excuse me, sir. My question is not 14. I mean that population under 14 is about 25%. And utilization of Ayushman Bharat by under 14 is less than 5%. I want how this can be increased, because their address and their concern and their health is most important.
I think, Dr. Swasthya, is it?
Yes.
I'm not an expert in this field, but I can say that the comparison should be, more ideal comparison should be the percentage of this age group that you're talking about in Ayushman Bharat compared to the percentage of this age group in non-Ayushman Bharat families, rather than the total population. So if it is 5% in Ayushman Bharat category, what is the hospitalization of the entire set of hospitalization in non-Ayushman Bharat category, what is in that age group? That would be a proper example comparison, yes, because all age groups would not have same kind of hospitalization.
Right, sir. I think if it is possible, this should be incorporated in future studies.
Sure.
It can be both. It can be both. Maybe there are certain packages which are missing for maybe the reason, but we cannot really come to a conclusion based on this, what you're talking about.
Right.
I think we'll have a question answer session towards the end, but we have a panelist of 3 experts. So जो उमाकांत सर ने findings बताई हैं, largely 2 चीज़ उसमें दिख रही हैं. एक demand level पे काफ़ी awareness है, of course काफ़ी सारी चीज़ों पे काम करना है. दूसरा issue है supply का, network काफ़ी बड़ा है, but state भी काफ़ी बड़ी है, 7 करोड़ से ऊपर आबादी है. एंड डिमांड के साथ सप्लाई साइड, हॉस्पिटल साइड को हम किस तरीके से स्ट्रेंथन कर सकते हैं, उस पर हम लोग पहले चर्चा करना चाहेंगे. सो मेरा फर्स्ट क्वेश्चन इज़ फॉर गोमती, एंड गोमती हैज़ स्पेंट अ लॉट ऑफ टाइम ऑन द प्राइवेट सेक्टर साइड ऑफ इंश्योरेंस एंड री इंश्योरेंस. हम लोग यूपी में और काफ़ी सारी स्टेट्स खुद इम्प्लीमेंट कर रही हैं, इंश्योरेंस के थ्रू नहीं कर रही हैं. So my question to Gomti is that for a state which is implementing the scheme itself, what are some of the ways to create that value proposition for the private sector hospitals to come and participate? And do you have any learnings again from insurance on, how do we really, learn from them and create that network?
Good afternoon, everyone. It's really humbling to see the august audience, and kudos to Sachi. You've been doing a terrific job in terms of utilization and customer satisfaction levels. I think this is one of the highest that I've experienced. I've been in government schemes still from 2008 onwards. So kudos to you, ma'am. So before I get into the question, I think one small part about the utilization of young lives that Dr. Srivastava had asked. In an insurance actuarial context, we always follow a morbidity curve. So it's not like if you have a universe of 100 and there are below 14 years, if the percentage is 14%, they have to use 14% of the pie available. It always goes through the morbidity curve. There are particular age segments where the number of, that is probability of diseases happening is higher. So they utilize the segment much higher. So there was, that's, I don't know whether probably we can have a detailed discussion around this. These are all very factually available global studies which will give you a clear idea of what is a morbidity curve, both genders and age-wise. And from an India context, we have seen a lot of experience analysis studies. It differs depending on which geography we are talking about. So probably we can have an offline conversation. Coming to your question here, there are multiple things that I've experienced in my 10, 12 years in government health, which might be useful. I'm sure you're already implementing it here, but three specific instances stand out for me. So one is what I've seen when the Tamil Nadu program got implemented. As a reinsurer, I got very closely associated with the project office for the first 24 months. There was the Ward 500 which they created. Till then it was a struggle to get an overcrowded hospital to take care of the government scheme as well. But a separate AC ward was created even in government hospitals, and a separate facilitation or embarking the number of beds for these patients was created in private hospitals as well. So the number of hospitals that you have in UP is slightly higher than what Tamil Nadu has currently. But clear focused beds creation helped in a significant way, because when the footfalls come into the hospital, they need a team to steer them on the whole process, because they are coming with a lot of pain, they are coming with disease. They get very, they feel very helpless when there is no facilitation happening there. So the Ward 500 was a significant change maker. The second thing which I still remember, in one of my formative, I would say, days in government health, I had a very good interaction with Mr. Babu Ahmed, who was the brain behind Arogyashree in Andhra. So he was the collector of Kakinada at that point of time. And I remember as a student, my father was with Department of Atomic Energy, so we used to live in a place which was like rural Andhra. Except Visakhapatnam and Hyderabad, there were no tertiary care treatment centers at that point of time. I'm talking about like 20 years back. But when I visited Mr. Babu Ahmed in Kakinada, he was showing the number of hospitals in Kakinada which had tertiary care hospitals. And the government hospital in Kakinada had a balance of like 11 crores which could be utilized in infrastructure development. So this brings the point that I have seen in few states, including Tamil Nadu, where there was a separate financial incentive structure which was created on how the money coming from government schemes get utilized in government hospitals. In the private sector, this already is in place, because many of the top hospitals in most leading states are part of government schemes, and they've been doing really well. So that is a second point which I thought I'll table. The third part, of course, is the softer point. So when it comes to deceased lives, again, how the care continuum is taken care of holds a big, I would say, the customer journey or joy of living, as Secretary put it across, is a very important factor. So normally we don't realize how difficult it is at the time. For example, when someone has cancer, whom to trust becomes a very fundamental question. So even people from the industry, like I've spent more than 26 years in the industry, I still feel very nervous about trusting a doctor or trusting someone who I have not grown up with. So generally I'll take help from my chief medical officers before getting through the whole treatment. And this has nothing to do with the hospitals per se. It has to do with the consumer psyche probably, because we are bombarded with too many details. We don't know which of them makes sense for us. From that perspective, the call center, which was suggested in the earlier session, makes a lot of sense. In this context, I actually have a live example which my current organization has implemented with the government of Kerala. So between July and December, we implemented a program for care continuum in cancer for 2 districts in Kerala, where there were 2,459 individuals who were screened for cancer, and 299 were found to be positive, and out of which a total of 189 chemotherapy sessions and 17 surgeries were performed. Why it might seem to be a small number, but the point which I wanted to make was the power was given to the beneficiary. It was on the app, and the whole, I would say, facilitation was done through a command center who are always available to them when they had to talk to someone to get their doubts resolved, take care of their palliative care, take care of the counseling, because the family goes through a lot of pain when these things happen. So these 3 are specific instances which I thought might be helpful from today's context. Thank you.
Thank you. Thank you, Gomti. So I think some of these things are also there in PMJ. So the facilitation kiosk, we have an Arogya Mitra kiosk at the hospitals. I think even from UP there are examples where specific Ayushman Bharat wards have been created. But I'll come back to you on the private sector again, but maybe I'll, ask Sudha who can bring, perspective at the national level. We still need to get the private, right? And for private, of course, the costing is one big factor. Plus, what we have also heard is that they do not want to empanel for all the specialities. And these are some of the policy barriers. So do you, any perspective at the national level, any considerations which are being thought of?
Thanks, Himani. Definitely always we understand that the government schemes need to work with the private, right? Because they are one of the key healthcare providers. So in that sense, some of the things that we need to keep in mind, especially to engage and sustain the private sector, because we have seen many times they are forced to be empaneled, but they get out. The moment they know that this is the level of monitoring, this is the level of effort that is needed to even get a small payment out of a particular patient through the system. So in that sense, what we could actually do is to make sure that these hospitals have a kind of a forum where they can actually be get any concerns addressed immediately. So we all know that yes, we have a hotline number for beneficiaries, 14555, they can call for everything. So what we did in the last 3-4 months was to ensure that the hospitals, private hospitals also have this hotline. So we have created a new hotline for them, that is 144713, where hospitals could also engage with the system and get their concerns addressed on a much fast track. So that actually helps them that they have somewhere to go, because they keep going round and round. 144713. So they keep going round and round. So that is one way where we gave them some confidence that we are here to, we will hear you. And we have an escalation matrix also for that, so that once any grievance is registered, we have a complete online system so that they can be tracked and resolutions are happening, and the concerned state or the concerned hospitals issues are addressed. This is one very critical thing which we feel that, maybe we need to popularize it more, because that has come in recently, but I don't know to the exact extent, whether all the hospitals in all the states are aware of it and are they using it. So that is one thing we can actually definitely do to engage already empaneled hospitals, right? So the second thing is for the engaged hospitals also, so that they don't go out. One is kind of the reconciliation on a monthly basis, because most of the hospitals, their concern is that fine, we get some delayed payment, or fine, we may get some. But when there is some deduction, they want to be very transparent. So it is important that they want their concerns to be reconciled on a faster basis. So a monthly reconciliation, what we call, I think, pre-DGRC. So that the district managers, I'm very sure the UP has a very strong DIU. So the district managers can do a pre-DGRC so that any concerns that has been raised by hospitals, any kind of things, they can actually engage with them. So this is for the hospitals who are already part of our system, so we sustain them. For the hospitals who are currently not part of the systems, and where do we want them? Because many a time we need to have targeted empanelment. So we need to prioritize. I think there is some analytics done for UP also, where we know that what specialty is not available, and it is not just the hospital being there. We have to do a very prioritized empanelment for the specialities, so that in a district, any beneficiary can avail most of the services, whether it is in public or private. And if we find some blind spots there, that some districts don't have particular specialities, and if we have a private hospital who's not part of it, I think this SHA has to be proactive to engage with that hospital to make sure that how do we get those hospitals back into the system. And maybe and for that, till now we didn't have a policy of such selective empanelment for certain specialities. And recently our board has approved that selective empanelment, sir, what you were asking in the morning. So that has been approved by the NHA board to make that policy change, so that only for tertiary care, not for secondary care, only for tertiary care, some of the hospitals where in a district where we don't have any public or private hospital, we can engage the hospital interested for that particular specialty, like cardiology or nephrology, or for neurosurgery, something which is high end, which is currently not available, and beneficiaries will have to travel out a lot. So I think that is one specific policy that we have tried to address. And with the differential pricing that we have gotten through the HPP 2022, that also gives some of the hospitals who are already in metros and other, where they will have an additional kind of incentive that their prices are adjusted. And along with the incentives that they normally get for being in aspirational districts or quality accreditation, these differential pricing would definitely bring in that regional variation in the cost of service. So that also makes the providers more engaged with the system, that now I am not the same kind of a hospital who's getting the same flat rate across all types of hospitals. Now I am differentiated because I provide a different set of services at a different quality, so I get paid a little differently, and that brings in a sense that that we can participate in the scheme. And another key thing that I would like to also say is that most of the time, in spite of differential pricing, we are actually paying a flat rate to all kinds of patients. If I'm a cardiac patient, I get the same 65,000 for a stent across all the hospitals and for all the patients. But what we have tried to do some pilots is that to have the complexity or the severity of the patient. Because some patients with comorbidities, some patients with complications need a different level of care, and we are currently not providing that to the hospital. The complications and any kind of additional comorbidities have to be absorbed by the hospital. So there is a tendency for hospitals to refer out severe cases or cases which need more intense resources, longer stays, so that they will not be, they do not want to lose out on those. So that is through the diagnosis related group payment systems to the providers. We are doing this pilot in 5 states in India, and we are hoping that that can actually be one of the very strong lever for providers to participate in this scheme. So I have interacted with a lot of hospitals while we were trying to gauge the pilot, I think they're very welcoming in that now they will actually get a patient-wise payment, which normally they do when patients come in from the private out-of-pocket payments. So in that sense, I think these are some ways to engage the private sector and continue sustain the engagement, and hope that these get uptake, they'll be able to have a better uptake in the scheme.
No, I think those are very, very concrete steps, and I'm glad what you are saying and some of the recommendations of the study are pointing towards that. We need a more targeted approach to get private sector. I would maybe, we've discussed a bit on supply side, Devendra, who actually works on the health system side and on the primary healthcare side, and he's of course worked in so much with the communities. From Devendra, I just wanted to understand that beneficiary empowerment is again one important pillar for any scheme, for anything to really work. And in the past, we are seeing that awareness is high, but it gets fragmented when you go down and start seeing where do I go and seek care, or what specialties are covered, and whether post-hospitalization is covered or not. And I think again, from what Sir said in the morning, that that whole simplicity in the process is not there. So any views on going forward, what are some of the tested ways on empowering the beneficiaries? What could be the way forward to really equip them with information, awareness? What would you suggest?
Thanks, Himani. So first of all, and I probably reiterate and repeat that, I think it has started from a zero, and as PSS sir mentioned, there was a COVID time, and in spite of that shortened period, there is a phenomenal jump in, you take all parameters. And now and this is a good inflection time also, okay, as we move forward, how do we go to the next level? And my general thinking pattern is, if you are not finding the solutions from that particular field, go back to another area from where you can draw the lessons. So I will draw the lessons from where I worked extensively. So for example, in the family health field, our traditional experience, and whether it's a polio eradication days or a family health days, generally 80-20 rule always applied. But in family health, when you look at multiple critical indicators, it is not 80-20. So let's take UP as an example. Recently UPTSU, I had requested UPTSU to run some analysis, and which are the districts where more than 5 critical indicators are they are not improving, and which are the one where by and large they are okay. So 1/3 of the district, they are always doing good. 1/3 of the district, either they are poor in all 5 critical indicators, or at least 3-4 indicators they are poor, and that is around 1/3. Now these are the, and in between of course there is 1/3. So these 24 districts, or 5 as a critical and 19 as less than critical, now that is where even our private facilities we are talking about private empanelment and all, but there are places where there is not sufficient private infrastructure, and the only way we can provide services through the public health facilities. Now there is a challenge and there is an opportunity. The way I look at it is, can we now prioritize these districts for strengthening additional services, or for adding on more services in these facilities, so that generally the base becomes then more stronger in these districts? That's the one point. And there is always a challenge between speed of expansion versus fraud control. Because if I am working for the government, I will be more interested in a fraud control, so that there is no such future challenges anywhere. But the speed of expansion is also important. So I think I I always find, and many states struggling with that concept of how fast we can go versus how fastly we can, that challenge is always there. And I think the geographical prioritization is key while we are looking at multiple other things. Coming back to your central question of beneficiary empowerment, I was in my village few months back, and my mother told me a story कि some of the close person in the village, they had a strong financial hardships just for the payment of severe morbid conditions for their daughter. Why? And I was in a way typical. Now you are a little away from the ground, so you start asking the question कि भाई क्यों, ये तो भाई मुख्यमंत्री आवास, ये भी सॉरी हेल्थ इंश्योरेंस योजना है, प्रधानमंत्री इंश्योरेंस. So the only challenge I realize is ease of process and not awareness. And how do we solve for that? And our traditional approach is, we will empower Ashas, we will empower ANMs, frontline workers, health and wellness centers, Arogya Mitras. And this is great, of course it is important. But I think in a state like UP, there is an impressive self-help group commodity. In the northern Indian setting, the rate with which the self-help groups are increasing, both in size as well as quality, is impressive. Now, this is the group, if we can involve in an effective way with the PRI, but self-help, I do have a tremendous belief in the power of self-help groups. So our generally fallback approach is Asha, ANM, Arogya Mitra, Health and Wellness Center. Of course that is important. And because this is a separate department, generally we are, so how can we layer on these messaging so that the beneficiaries can get more and more empowered. And the last point I would like to say, and my senior colleague Dr. Santosh Matthews has already mentioned, when the scheme was launched, it was, so that analogy between the health department as a steward of entire health of the population versus the health department as the steward of the healthcare delivery through its own infrastructure, right? Now, as the department is changing from the steward of own their delivery mechanism to the steward of entire health outcome, the private becomes naturally important and all. But there is no place in the world where primary healthcare services through the private sector has succeeded. It has worked in small places, but not in a big and at scale. So for the primary health care, always public health delivery mechanism will continue to be a powerful mechanism. So how do you seamlessly integrate primary, secondary and tertiary, either through the form of call center? COVID had provided so many opportunities where you could see how many beds are available in this sector, how many facilities are here, how many doctors are available and all that stuff. Can we use that lesson? Last point, and I will stop. There are powerful examples within UP itself for empaneling. For example, Hausla Sajidari, a very narrowly focused family planning initiative for involving private sector, where one of the common complaint with the private sector is, मेरा timely payment नहीं हो जाता, number one, and second, I have to put lot of papers for renewal for every year. These two issues were addressed in the Hausla Sajidari platform, which was coordinated by SIPSA and NHM. I'm just trying to say that there are multiple powerful examples which are available within UP, in India, outside India, and how can we capitalize on many of them. Thank you.
No, thank you. Sir, can we open the house for question answers? No. Yes. And please state your name and who do you want to ask the question, and please don't ask PS, sir.
side, we have reserved these packages for the government sectors only, like LSCS and high-risk delivery, eclampsia delivery. And every district has not a developed facilities for government sector. Like if I talk about in a particular district, it's not always they have a tertiary care center in that district. They have a simple government hospital there. They have to refer their patient to other district hospital for the Ayushman beneficiary if they are covered in the Ayushman and they are under eclampsia or high-risk delivery. So what I personally believe, sir, the package should at least you should include the medical college in it. They are running shoulder to shoulder with the district authorities in that. So the LSCS or eclampsia or high-risk delivery package should the medical college should be involved, and the restricted that block delivery packages for the government sector which are reserved for the government sector should be open to the medical colleges also. That's my personal submission. What's your take and what's the idea behind it? I want to know about it. Why they have been reserved for the government sector now.
So I think
Thank you so much.
only Dr. Sudha can answer that.
Yeah, I think that's a very important observation, and till now it was the same. The status was that these packages were open to both the public and the private. One of the reasons that this has happened is because they're trying to rationalize the packages which are already covered under the national programs. Because institutional deliveries, institutional things are also being offered through the private sector through other programs of the RCH. So that is one reason that they did not want to duplicate those efforts under PMJY and also under this. Though I personally feel that, there is not much merit in what we are doing, but I will take that message back that how do we at least include the medical colleges, right? So that is one definitely we need to work, because there are many scenarios where a normal delivery is converted into a cesarean delivery, and that hospital or the facility may not have the skill and efforts to handle complicated delivery, because we have opened the high-risk deliveries to the private, but then we are blocking the cesarean section. So I do, as a medical person, I do understand that there is not much rationale, but definitely this is something that is coming up at the resource management level, and to avoid some duplication of resources. But this needs more thought. Currently this policy change has come in, but we are still exploring it. And one of the thing is we have given a lot of flexibility to the states. If states, sir, because we do understand some of your districts don't have those capacity and you want to open it up, you just need to write to us, and then, because we don't want to open it up across the state, because there are districts where there are very good facilities even in the public, we don't want them to be bypassed. But if there are specific facilities or districts where you feel, and you can write strongly to us saying that this is what the states have a complete flexibility on engaging that, and only thing is financially for some time until the policy decision is made, that financial burden may be taken up by the state when it is opened into the private. But we will also try that if we can justify that and get that cleared for you. Definitely we need some representation from the states, because some of the states have come out strongly, like Kerala has got it back onto their IT system and said that no, we want to keep it open. So though the national decision policy might be different, states can definitely ensure that your side of the issues could be put up. And we have made that change for Kerala to make it open, and there is already a lot of MP has requested that they even want a specific district and a specific hospital where it want to be opened up. So we can even look at that level. IT has the capacity to do it, but as a blanket policy we are not able to do it. But when there are specific requests and we have a lot of justifications, I would request ma'am, if you can put it up to us, then definitely we will see how we can resolve that. That's all from me.
Himani, I have a question for Dr. Sudha again. Thank you, ma'am, for answering Rohilkhand Medical College's question, because we were discussing just this thing in the morning. And specifically, like we were discussing, that there are certain procedures that if suppose a person that are already now in the private sector group, but when now they are उसका consequence जो है वो reserve हो गया public में. Like अगर कोई patient high risk delivery patient आती है and उसके पास obviously high risk delivery का अगला stage ही cesarean delivery है. तो high risk delivery patient अगर public hospital में आती है, उसका अगला stage cesarean delivery होता है. तो प्राइवेट हॉस्पिटल में, सॉरी, तो अब हाई रिस्क डिलीवरी से वो प्राइवेट हॉस्पिटल में अगर सिजेरियन की आवश्यकता है तो फिर एम्बुलेंस से उसे कैरी करना, तो वी आर एक्चुअली पुटिंग हर राइट लाइफ एट रिस्क. सो आई एम जस्ट पिचिंग फॉर यू, जस्ट सेइंग व्हाट यू सेड. My question is actually, I want to understand a little about the concept of partial empanelment that you spoke about just now, because what I understand, and possibly we just overlooked the general policy of NHA, was that हमारे यहाँ वैसे भी अभी partial empanelment होता है, मतलब because we thought the general policy was obviously कि cherry picking नहीं करनी है हॉस्पिटल्स को, जो उनके पास फैसिलिटीज़ हैं वो सबके लिए इम्पैनल हों. बट इन द इनिशियल स्टेजेस वी अंडरस्टूड कि सब हॉस्पिटल सब चीज़ के लिए कंफर्टेबल नहीं होंगे. सो सम हॉस्पिटल्स दे गॉट देमसेल्व्स इम्पैनल फॉर फ्यू ऑफ द फैसिलिटीज़ दैट दे हैड, नॉट फॉर ऑल, एंड सो वी अलाउड देम, एंड सो दैट कंटिन्यूड. So in that sense, partial empanelment is probably already happening in UP. Now that you have an OM for it, it further validates what we wanted to say. But what was the thinking beyond this? Why you had to come up with a specific OM? That is one. And secondly, cherry picking का तो अगर करेंगे hospitals, तो now we are pushing the hospitals कि वो ना करे cherry picking. So we have written to the hospitals and said कि whatever facilities you have, you please empanel yourself for all the facilities that you have, all the specialties that you possess. For example, अभी यहाँ पे अपोलो हॉस्पिटल है, वहाँ पे कैंसर केयर अच्छा होता है, बट अपोलो हैज़ नॉट एम्पैनल्ड देमसेल्व्स फॉर कैंसर केयर, वो सिर्फ कार्डियोलॉजी के लिए आए हैं. सो कॉर्पोरेट हॉस्पिटल्स भी ये चेरी पिकिंग करते हैं, नॉट टू टॉक ऑफ स्मॉल हॉस्पिटल्स. सो व्हाट इज द लॉजिक, एंड विल दिस ओएम और दिस फर्दर सेइंग बाय एनएचए दैट कर सकते हैं आप चेरी पिकिंग, सो टू से, विल इट नॉट सर्व एज अ इंसेंटिव फॉर द हॉस्पिटल्स टू, ओके जो हमें फ़ायदा होता है वो हम कर लेते हैं, जो नहीं होता है वो नहीं करते हैं?
Yes, ma'am.
संगीता, इसमें न्यू टू द सेक्टर, बट सपोज ए प्राइवेट हॉस्पिटल सेज कि नहीं, मेरे को कैंसर का नहीं करना है, मेरे को सिर्फ कार्डियो का करना है. सो वन वे ऑफ लुकिंग इट इज़ कि वो कैंसर का क्यों नहीं कर रहे. द अदर वे ऑफ लुकिंग इट इज़ कि क्या मेरे को कार्डियो की ज़रूरत है नहीं. अगर मेरे को कार्डियो की ज़रूरत है तो मैं उतना क्यों नहीं एक्सेप्ट कर सकता हूँ.
Thanks, ma'am. Definitely, the OM does not just say you can cherry pick. That is not the content of the policy decision. What it is saying that do the gap analysis. So in districts, in places where you do not have the facility, state has to give a justification of why they will have to do the selective empanelment. So it is not automatic or a blanket that अब सारे hospital empanelment selective में हो जाएगा, ऐसा नहीं है. The main thing here is, जिस district में हमें कोई भी super speciality नहीं है, मगर एक हॉस्पिटल है जो वो दे सकता है हमारे बेनिफिशियरीज के लिए, एंड वी आर आइडेंटिफाइंग दोज स्पॉट black spots and ensuring that there we are creating that, and it is only very temporary. We have put in a guideline of that selective empanelment will be permitted for a period of maximum 1 year, and we will again relook at with the states in the next financial year and see why there is no facility, and they can look at creating that facility through their public health system at least within that time. So wherever they can identify, if there is already a good medical college or a district hospital, we can encourage them, okay, why can't you put in a cardiac unit in at least in the next 1 year, because now we are paying the private in your own district to so much money, and this is the revenue you can generate. Yes, sir, definitely, that is one. See, one is there is no hospital or you don't have capacity to treat all the things that are coming. So the justification from the analysis has to come in as to the reason of why you want to allow the selective empanelment, and we are limiting it only for tertiary. For a hospital that gets empaneled, it has to empanel for secondary services, whatever they have available. So if they cannot say, I will not even apply for general medicine. Not, it is left to the state only, so we are not allowing, we are not doing this. So the state will take the call, state, if they want, they will allow. We are not doing any empanelment. So the empanelment process is 100% state activity. We only get the, if for this release, if for this additional relaxation, we just say that how justified you are when you
And
request
ma'am,
that in the IT.
on the one hand, maybe we are giving more power to the patient to choose, decide कि क्या है, but at the same time अगर हम specify करते हैं कि ये वाला hospital it has perhaps sufficient number of specialty, it doesn't need to empower for more. I think at the other hand we are also curtailing the right to choose of the patient, because we have given the right to the patient to go wherever he seeks, he can seek. So in any case अगर उसके district में नहीं है कोई तो वो बाहर जाके भी ले सकता है treatment. And I don't think in a scenario like UP and in a scenario like Ayushman जहाँ पे कि lesser है and the patient has to kind of move out and all, anything is less, क्योंकि जितना ज़्यादा होगा it's always good, कि जितना ज़्यादा specialty हमारे पास होंगी, so I will not have to move out for more. तो rather than pitching for that more and more, whatever you can spare, please provide it at the doorstep at the patient. Then it is his right to choose कि वो यहाँ जाना चाहता है, झांसी में कराना चाहता है या MP में कराना चाहता है. But at least we give him that facility at his doorstep कि वो करके तो दे. So I think we have to relook at it.
Sure, ma'am. It is for some of the states where they are having those hospitals, but the hospitals are only interested to empanel for certain specialties. So again, it is a call that states will take, and they might make the decision whether they want to open that, selective empanelment for that specialty or not.
Sir, with your permission, I think we'll close because we have another session. Would you have some closing remarks, or we can conclude? Thank you, everybody. I think we've got some very concrete ideas, at least on the hospital empanelment side, and we'll have to work a lot with Dr. Sudha to figure out the partial empanelment.
Before we end the session, I would like to call upon the CEO Sachis to please felicitate the panelists. We can give a round of applause. That was an interesting conversation, wasn't it? To PS sir. To Dr. Sudha. To Shri Devendra Khandayat ji. Dr. Umakant Dash from IRMA. And he'll also be felicitated with the Amrit Jan-Samman. Srimati Gomati Venkatachalam, and Ms. Himani Sethi, Director Programs, Access Health International. Thank you so much, all the panelists, for that wonderful discussion and paving the roadmap for us for next year. Thank you, CEO ma'am. As in many economically developed countries, increasing life expectancy, changes in lifestyle, and increased exposure to risk factors have led to an increase in occurrence of cancer and other non-communicable diseases. The increasing cancer incidence, coupled with resource limitation of developing countries, calls for the need of optimizing care, expanding care, and reducing the burden. In India, while the incidence is lower than in the Western nations, the mortality is quite higher, suggesting low health service effectiveness. It is estimated that approximately 2 to 2.5 million cases of cancers are reported annually, out of which, unfortunately, nearly half die. And this burden will be doubled by the year 2026, according to the Indian Council of Medical Research report. In Uttar Pradesh, there is changing disease burden between 1990 and 2016. The disease burden due to non-communicable ailments increased from 48 to 75%. And in Uttar Pradesh, from 7% in 1995 to 19% in 2004. Based on this reference, our next session is about prioritizing cancer care under Pradhan Mantri Jan Arogya Yojana, increasing drugs, diagnostics, and targeted therapies. What is the context? What is the current way? And what is the way forward for us to move in the scheme to bring cancer care on the forefront? And the theme thought for that is that cancer care should be seen from a different lens of other health benefit packages, I would like to call upon the moderator for this session, Dr. Gaurav Agarwal sir, who is the Chief Medical Superintendent, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Agarwal is a professor of endocrine and breast surgery and also the CMS. He is also the convener of the SGPGI Breast Health Program. He has been part of the Ministry of Health and Family Welfare, Government of India Technical Committee, which drafted the National Clinical Practice Guidelines for Breast Cancer Management and has contributed to the global breast oncology and surgery practices. We are very, very honored to have you, sir.
Thank you very much, Ms. Manisha ji. First of all, I wish to thank SACHI's and the National Health Authority for involving me in this very significant event. I wish to congratulate all the stakeholders for completing very successfully these 4 years, first 4 years of the Ayushman Bharat PMJAY, which indeed is a game changer. I mean, this phrase has almost been used as a cliche, but nothing can be more truly stated about this scheme than this has been a great game changer. Often we have heard the simile of this glass half full. In context of cancer care, the PMJAY support, I would say, is a glass 1/4 full. And often I'm asked, why is it only 1/4 full? And I have to tell many of my colleagues that at least we have a glass today. We have some support, some government provided insurance for providing for this very expensive, very trying treatment of cancers. And so I feel this session now, this plenary on prioritizing cancer care in PMJAY is very relevant. And I'm happy that we have such an eminent panel today. The chairperson and the key speaker for this session is Dr. Shankar Prinja, who's the Executive Director, Health Policy and Quality Assurance of the NHA. Dr. Prinja would be joining us virtually, and is he connected? Yeah. And we also have some very eminent presenters and panelists. This includes Dr. Anand Mishra, who is the professor and head of endocrine and breast surgery here at KGMU. Dr. Poonam Gupta, she's from the Podar Hospital and an eminent radiation oncologist. Dr. Sandeep Jasuja, the medical superintendent, State Cancer Institute and head of medical oncology from SMS College, Jaipur. And did I miss anyone? Okay. And the two presenters, the presenter, Dr. Kirti Srivastava, Professor of Radiotherapy here at KGMU. So may I request all of you please to come up onto the stage. Dr. Kirti, Dr. Jasuja, Dr. Anand Mishra.
We can have a round of applause, please.
And Dr. Poonam Gupta. So we can start with the keynote. Dr. Prinja is connected. Can I request you to kindly take this take.
Sure. Thank you very much. And thank you to the state leadership, SACHI's, for organizing this this very important event and for the invitation. And my apologies that I could not be there in person because of some flight issues. But I'll try and cover some of the salient points that I would have wanted to talk about. So I hope my slides are there in full view. If somebody can just confirm that my slides are visible.
Oh yes, your
Yes, it is visible, sir. You can go ahead.
Thank you so much. So what I'll try to cover in the next about 15 minutes is give you a bit of a context in terms of the cancer care packages that are available, the level of utilization that exists. Given the context that was set in by the speaker earlier, where it was being talked about that there are new types of targeted therapies that are available in cancer, and we need to make some consideration about inclusion of those targeted therapies and high-end technologies, etc. So herein I would like to also give you a bit of a context in terms of application of health technology assessment and how we are trying to make decisions about inclusion of newer therapies for not just cancer care but all types of other health benefit packages also. I'd also briefly touch upon a new digital solution that we have proposed for further improving the financial risk protection, and this is much more specifically relevant in the context of cancer care. And finally, I have a couple of slides to talk about the quality of cancer care as well. So in terms of the health benefit package, I think that cutting across all different specialities that we have within PMJY health benefit package, the rate of growth in terms of the number of packages that have been covered under any speciality, I think the rate of growth in oncology has been by far the highest. So we have almost, in the last 4 years, we have increased the number of packages by almost 5 times in the oncology space. So from about nearly about 112 to now about 557 packages that are available across medical, surgical and radiation oncology specialties. So this increase in the number of packages, I think in the last 4 years since the scheme's inception within the oncology field has been the highest compared to all other specialties. And this increase has happened in all the 3 different subspecialties of oncology, which is either medical, surgical or radiation oncology. Now, if you look at the utilization levels, the pie chart on your left side is a bit misleading because while it does show that 83% of the overall utilization is for medical oncology, but that happens to be shown in this way because the medical oncology, each cycle of the chemotherapy regimen gets counted as a separate claim, and as a result this is the distribution of the claims but not the distribution of in a way number of patients who've been treated in different specialties. So we can take that with a pinch of salt. But what we see on the right side of the slide is the rate of increase in utilization across the years under PMJY, and here you can see that there has been a very steady increase in the utilization of all 3 different specialities packages. So there has been like 166% or 161% increase in medical oncology and surgical oncology utilization. So that's quite a significant increase, and that is a manifestation of both the supply side and the demand side intervention. So from the supply side, as you saw, that the number of packages have increased very significantly. And from the demand side also, we know that there is an increasing burden and there are more and more people who are now seeking care for cancer. If you look at the distribution of cancer care across different states under PMJY, what we have tried to show here on this slide, on the right side you see the prevalence as per the cancer registry estimates. So this is the actual burden of disease picture. And on the left side, we have the heat map across states where the plotting of the color or the gradation of the color is as per the level of utilization. And the level of utilization is also not in terms of absolute numbers, but it is number per as a percentage of the total number of individuals who are insured in each of these states. So by and large, we see a very similar kind of a pattern. You see that the utilization, the density of utilization matches the density of the actual number of cases that are prevalent in each of these states. So you can see the color shade by and large matches on both the maps of India, except for a few exceptions like Gujarat you see here, where the color is much darker. Here it is relatively not that dark on this side, and that probably stems from the fact that we have a few cancer hospitals in Gujarat which cater to a very large number of cases. But by and large, the picture that we see is that it somehow matches with the burden of disease, which means that the scheme by and large is able to deliver care in an equitable fashion. That means the utilization is as per the need estimates, so which is something that should give us some bit of confidence. If you look at the utilization by the type of provider, about 60% of the total oncology care has been delivered through the private sector hospitals, and about nearly 40% is through the public sector hospitals. Now this also to an extent also matches with the ratio of the empaneled providers as well, where about nearly the same ratio exists in terms of the empaneled providers specifically for oncology care. Now that was in terms of the coverage that we have and the utilization that we have. I will now talk about some of the new initiatives in oncology space. So as I did mention that we do recognize that there are new interventions that are coming up in the context of different healthcare services, but oncology is one specific field which is very special in the sense that the rate of growth of newer molecules, newer targeted therapies, newer radiation oncology treatment modalities, etc., that are coming in are far more than perhaps the other specialities. So what we have placed now on the NHA portal is a portal where you can submit your requests for inclusion into the health benefit package. So this is a formal channel through which you can submit any new drug, device, surgical technique that you feel that which is not available in the health benefit package but should be included. And in the month of April, we came out with a policy on provider payment and pricing, where we outlined the detailed approach of how the processes would be followed for the purpose of assessment of any new inclusion request that comes in. And primarily what we are trying to use are standard principles of health technology assessment, whereby interventions would be judged based on the level of cost effectiveness that they represent, because we do consider that these are decisions that have to be made for utilizing public money, and so we should try and maximize the value of the money that we are spending. So as a result, this becomes an important prerequisite in the decision making. And this is something that is being used not just for making decisions about inclusion of newer therapies, but also for developing standard treatment guidelines for the existing treatment modalities as well. So for example, this is a very classical case, I think this comes in discussion in different forums, which is that how long should you be giving trastuzumab in cases of HER2 positive breast cancer cases. And there has been a variety of requests coming in for more longer duration therapies up to 1 year, which means about nearly 16 or 18 cycles. Originally this was available only for 4 cycles. Now based on the evidence that we reviewed, we found that it is cost effective to be given up to 8 cycles, which means about 6 months of therapy. And this was included in the standard treatment guideline. So this is just to say that this is how evidence is being used in order to make decisions for standard treatment guidelines. The other third component that I wanted to talk about was the fact that cancer is definitely a very special case, specifically when we're talking about the financial risk protection and the extent of out-of-pocket expenditure that people face. One of the key characteristics that there was a large nationally representative study that was undertaken very recently, which specifically looked at the out-of-pocket expenditures for cancer care. There were 2 very important findings that come out of that study. First is that the overall out-of-pocket expenditure, if you look at it, in specifically for cancer, the annual expenditure that is incurred in outpatient care is more than what is incurred in hospitalization settings. So that's a very characteristic finding that we have specifically for cancer. The second important finding that we have is that if you look at the distribution of the expenditure that people have to incur in outpatient care, which typically is not covered under the scheme, then you find that more than 1/3 of that is actually on diagnostics. So the gray part of this pie that you see is actually the diagnostics. The red part of the pie is medicines, which to an extent we do cover in our scheme also, because some of the medications for cancer which can be delivered in daycare setting are covered as part of our scheme. So I would say that some part of this red part of the pie is covered, but this is largely uncovered. That means more than 1/3 of the total out-of-pocket expenditure in outpatient care which happens on diagnostic is something that is not covered under the scheme. We have made an exception specifically for cancer as part of the PMJY scheme, and one of the digital prepaid solution which was launched by the Honorable Prime Minister last year, we have tried to make use of this e-rupee as a mechanism to pay for the cancer diagnostics, specifically the ones that are used for making staging decisions. So what I mean to say is that we are not proposing that you use this digital prepaid voucher to pay for the diagnostic services to make a diagnosis for cancer, but it is that after you have a histopathologically confirmed case of cancer, even beyond that, you have a number of diagnostic tests that you have to subject a patient to in order to stage that patient and in order to even make decision on how you treat that patient. So in order to do that, we have proposed to introduce this e-rupee as a digital prepaid voucher, which is a kind of a purpose-specific and person-specific digital voucher, which is given to a patient on his mobile phone, comes in the form of this kind of a QR code on a smartphone, but if it is a feature phone, then it comes as a kind of a text message with a string attached to it. And this is something that the patient can redeem at any diagnostic lab, be it within the hospital or outside the hospital. So the way that it works is that if you and I'm just trying to show you a process flow, that a patient who visits the hospital who has a confirmed report that he is positive for cancer, then thereafter if the patient is, let's say, of different types, whether it is a head and neck cancer, oral cancer or breast cancer, and there could be a number of other types of cancers as well, then thereafter you can raise a pre-authorization for subsequent advanced diagnostics that are needed in order to stage the patient appropriately, and that information is used to make decision about the actual treatment. And much of this doesn't get covered in our routine process flow, because the decision to treat a patient for, let's say, using chemotherapy or radiation therapy or surgical oncology procedure actually begins once you have all these diagnostics available, and then you raise a pre-authorization. So in our routine case, the opportunity to pay for these diagnostics or cover these diagnostics is not very comprehensively covered. So this is just a small snapshot of the kind of investigations that are covered as part of this. So these are the kind of packages that we have. So if you look at breast cancer, we have this early breast cancer. If the patient is clinically in early breast cancer, then these are typically the investigations for which vouchers can be created. It is chest X-ray, ultrasound, immunohistochemistry, mammogram. Similarly, if you have a locally advanced breast cancer, then you have coverage for a lot of these diagnostics, including the CT and bone scan as well. So these are the kind of diagnostic support that is offered, and this is something that is likely to bring down the expenditure for cancer patients specifically. And with this exception to the use of diagnostics, to the use of PMJY for paying diagnostics in relatively outpatient setting has been made only and only for oncology space. Now this is the last part of my talk, where I wanted to focus a little bit also on the quality of care. And this is specifically because last year we introduced several data fields in our transaction management system, which was specific to the disease, which is cancer. And the idea was that we wanted to make use of this data in order to judge the level of appropriateness of care or the quality of care. Now, interestingly, what we found after about a year of its implementation is that there were about 17 data fields that were introduced. But out of the 17 data fields, about 7, which is about 40% of the total data, they were either not entered or they were entered in a completely non-analyzable form. So, which means that this data is completely of no use. So, the remaining 59% of the data fields, which is about 10 fields in all, we then tried analyzing the information that was available. And these are fields like information related to laterality, sequence, the clinical extent of the disease, staging, etc., or the type of treatment given prior to disease. So the hospitals are supposed to enter this information in the TMS specifically for cancer. Now, if you look at these individual data fields for which at least the information was supposed to be analyzable, again here, quite a number of fields that you see in orange color or on top are those which were invalid entries altogether. So my request to all the participants here is to make sure that we train our PMAMs in a way, and we train our doctors also, that they are able to provide this information in a more appropriate manner on the case sheets, so that this can be then included in the TMS while the case history is uploaded and the claims are submitted. Then we also tried looking at for certain types of packages, and these package names are there on the bottom of this axis. We tried looking at that in 4 of these packages, where you can make very characteristic or clear-cut distinction that where a particular case should have been treated using this package or not. In other cases, it is relatively very difficult to judge by just looking at the data that is available to us, but in these particular 4 packages, it was relatively more easier to make this decision. Although within this also, it is not always black and white, there are gray areas as well. And then we tried classifying the states into those where these packages are used very infrequently, or the ones which are where you use these packages very frequently. But the point where what I'm trying to emphasize here is that if you see the bars, the red color or this orange color portion on the top of each of these bars, this reflects the proportion of cases where perhaps the use of this particular package was not compliant as per our standard treatment guidelines. That means cases of such clinical nature should ideally not have been treated with these packages. So this is what I mean by appropriateness of care. And the ones that are shown in yellow, we are presuming these to be compliant with SDGs, and the ones which are in green are the ones that are definitely compliant with the SDGs. The ones in yellow, I say it is presumed because given the clinical information that was available in the TMS, we assume that it is likely to be correct. So what the message that I want to give is that we definitely need to reduce the extent of this red portion of the bar, because we want to make it more and more compliant with the standard treatment guidelines. And this is the clinical compliance of the standard treatment guideline. This is not actually just the insurance compliance. This is the clinical compliance to how the care should have been done. Definitely, the more the utilization, you can see the less is the degree of non-compliance. So if you go to states which have a large utilization, that means they have greater experience in terms of oncology care, you have much lesser proportion. Whereas this proportion increases in those states where the utilization in general is low. And the last comparison that I also wanted to show was between public and private. And here again, the key finding is that public sector, the compliance to standard treatment guideline is actually better than in the private sector. So there is a greater compliance to standard treatment guidelines, more appropriate care that has been given to PMJY patients who have been treated in public sector facilities as compared to the private sector facilities. So we need to be a little bit more cautious in terms of the utilization of services, etc. So finally, I would conclude with just 4 key messages. I think we have a benefit package for oncology services which is decently comprehensive, covers several different surgical, medical and radiation oncology packages. We need to definitely be rational in terms of inclusion of newer therapies, because we do recognize that there are costlier treatments, molecules, technologies that are available, which may add very little in terms of survival benefits or quality of life. So efficiency needs to be a driver of our decision making in considering inclusion of newer packages. I would urge the state leadership to consider inclusion of e-rupee for use of diagnostic services. It's a very innovative digital solution. It is available not just, I just mentioned it for oncology services, but the general construct is for all types of diagnostic services, and we can have a separate discussion on that as well. But right now what I showed was specifically a use case for oncology diagnostic services even in the outpatient setting. And finally, I would urge all clinicians sitting in the audience to perhaps take a note to make sure that the provision of care that is delivered in the hospitals is as per the standard guidelines and as per the efficient practices. Thank you very much, and I'll be happy to answer any questions.
Thank you so much, sir. That was quite insightful. And definitely ABPMJY has cover for treatment of cancer, all under radiation, medical and surgical oncology. However, it was greatly felt that a little more insight is required into the patient journey from screening, diagnostics, treatment, adherence and health outcomes perspective, not forgetting the household expenditure despite an insurance coverage. And understanding all these elements which are very critical for developing pathways for standardized care, Sachi's has done a collaboration with King George's Medical University, thought leaders, Roche India Healthcare Institute and Access Health to understand an initiative towards strengthening capacities for cancer care in the state. The objective of this strengthening program is to get insights into patient journey in cancer treatment under PMJAY and otherwise, challenges faced by providers and program implementation under the screening, diagnostics and treatment, and develop a near-term roadmap towards increasing the standards of care. With that note, I would like to call upon Dr. Kirti Srivastava, Professor, Department of Radiotherapy, King George's Medical University. Madam is also the in charge of the hospital-based cancer registry program at King George's Medical University.
Okay. Good afternoon, everyone. First of all, I would like to thank the organizers, Sachi's and Access Health International, for giving me this opportunity to deliver my talk here amongst you all and convey my thoughts on this very important aspect of cancer care delivery, which we are facing in day-to-day practice in our medical college where we are dealing with the patients. And the current challenges which we are facing is the huge number of patients. Although the incidence as compared to developed countries is less in India, but taking into account the population, the number is quite huge. And on the top of that, we have very limited resources and the limited manpower which is not actually trained for handling the cancer patients. And besides this limited resources and manpower, we have cases presenting in very advanced stages. So whatever resources we have, we are actually using them to treat patients coming in advanced stages, and that is why there is very little impact on the outcome. And therefore, probably there is a thought in the public that cancer to theek hi nahi hota, because the time when the patient reaches to us, they are in such an advanced stages that the results are really very poor. And the other thing is the access to care and the availability of care, which we are discussing, that even if the packages are there, public is not aware of it, they are not utilizing it in time. They keep thinking that paise kahan se aayenge treatment ke liye, so they delay the treatment. And so we need to publicize this, that yes, if you will reach to the right place, you will get help from the government, and so you should not delay coming and seeking help. So in next few minutes, I'll be talking about the burden of cancer, especially in the state of Uttar Pradesh, the resources which are required, the current national program which is going on and what has been done in that, the availability and utilization of cancer care services in PMJ, which is the main topic of concern which we are here to discuss about. Then the findings of the study which just Manisha told you about, that we are conducting this study, and the interim results what we got, I'll be discussing them here in front of you. So the burden of cancer in the state of Uttar Pradesh, you can see here, the prevalence is around 260 cases per lakh population, and the most common cancers are the breast cancer, cervical cancer, colorectal, lip and larynx. And therefore, we have around 6 lakh persons living with cancer in the state of Uttar Pradesh at some point, at any point of time. Then the incidence is highest for breast cancer, and the second highest is stomach cancer, and the mortality is highest for stomach cancer. So you can see there is the prevalence of stomach cancer is not there because the mortality is very high. Next. Now what we are saying repeatedly is that the patients are presenting in advanced stages. This you can see here when we compare it with the developed countries. The percentage of patients which are presenting in advanced stages, if we talk about breast cancer, it is around 68% patients presenting in advanced stages. Similarly, the lung cancer, around 78% patients are presenting in advanced stages, so not much can be done for them. Similarly, for cervical cancer, it's 62, and prostate cancer is 58. Next. Now, the need of the resources, which is quite high. The human resource to cater the increasing burden, the requirement is there for around 570 to 760 radiation oncologists, because the need for radiation oncologist is very high, because around 60 to 70% of the cancer patients, they need radiation at some point of the time during their journey for cancer treatment. 380 medical oncologists are required, 380 surgical oncologists, pathologists, and then the radiation technicians, they are required to deal with the increasing burden of cancer. The equipments, as per the norms, we need around 1 megavoltage, 1 brachytherapy, 1 CT simulator to cater to around 1,000 new cancer patients. But the scenario is very bleak. We have the need, if you calculate with this, is around 200 machines per in the state of Uttar Pradesh. But exactly I cannot say, but we have around 50 teletherapy machines in the state of Uttar Pradesh. So the difference is quite high. So what should be done for this is to map the existing manpower. We should train them. We should do the capacity building so that the cancer is detected in early stages. Engage them in providing care as a part of cancer grid. This is also very, very important. The mismanaged cases come to us, they get some kind of treatment in the periphery. Wherever they go, they get some chemotherapy or some different kind of treatment, not as per the standard guidelines. And when they come to us, there is not much to offer for them. Now, increase the number of seats in different specialty. Obviously, then only we can fill in the gap. Then increase in the allocation of funds, which is very, very essential. As in my department, we have only just 1 linear accelerator and tocobalt machines, and there is a waiting list of around 1 to 2 months for the patients who are coming and waiting for their treatment. So and there are 2 bunkers ready to be filled by the equipment, but because of the lack of funds, we are not getting this equipment. So we have again asked the government to give this so that we can reduce the waiting list to for the patients. Then there are newer drugs which are coming up and getting approval from DGCI from time to time. So the standard treatment guidelines which are there, they need to be revised, and inclusion of new drugs in the NCG guidelines should be there, but the cost factor should be discussed thoroughly, And the experts in the subject, they should only include those drugs in the guidelines, and we should not blindly follow the NCCN or the ESMO guidelines because they do not fit in our setup. Whatever, if they recommend immunotherapy, it's not essential that we should give chemotherapy unless and until it is in our own guidelines that it has to be mandatory to use them. Now the cancer care program which is currently being run by the government, the NPCDCS program, which covers the cancer disease also, and the focus is on the health promotion, early diagnosis management and referral of cases, strengthening of infrastructure and capacity building. So this is very, very important, and the NCD clinics have been established in around 55 districts and 20 more are in pipeline. And in the 2030 vision of the Sustainable Development Goals, establishment of these NCD clinics is envisaged in all 75 districts. And the PMJ is providing secondary and tertiary care facilities to cancer patients through the public and private empaneled hospitals, which we are discussing here. And the screening program for oral cancer, breast and cervix cancer is going on in the periphery. And on the right side, we can see the pyramid starting from the sub-center where we can focus on the screening, the opportunistic screening and guiding them and making them aware of the symptoms so that early detection is done. Then going to the CHC level, then district hospital, and then the tertiary care level. Next. So as has been discussed, only 64 empaneled hospitals under PMJ are offering cancer services. These services are majorly limited to large urban centers. I'm not going to talk about much in this because already it has been discussed here. Next. So these are the results of the study which we are currently undertaking here at KGMU, and this is a qualitative study and to understand patients' pathways for seeking cancer care and challenges and barriers. And 60 patients have been interviewed from various districts, Lucknow, Sitapur, Gonda, Bahraich and Hardoi, and the salient sites delays in reaching the right facility. The delay in screening and diagnosis, delay could be up to even 2 years. And the reason behind that is the low awareness and lack of information on symptoms. Fear of diagnosis, especially high among women, cancer is a deadly disease. ये बहुत ही ज़्यादा common है, patients को ये अपने symptoms को बताते नहीं हैं कि कहीं diagnosis cancer की ना बन जाए और इससे बहुत ज़्यादा time waste होता है इसमें. So we need to tell them that if it is diagnosed early, you will get full cure and you can have a healthy life after that. So self-medication is another very big problem in periphery. People keep, not even periphery, you can say in the urban areas also, people do the self-medication thinking that it will resolve on its own. And that's how it keeps on growing. So delay in reaching the right hospital is another very big problem. So unable to decide where to go, and most of the time patients are guided to go to Bombay, Tata Hospital, and and most of the time what we see is that they go there, they're advised treatment and they again come back to us, and in this process they are spending around 1 to 1.5 months and the treatment is delayed. Now time taken to arrange money and arrange logistics is another big problem. They think कि cancer का इलाज तो बहुत महंगा है, पैसे कहाँ से आएंगे? If they are aware of these schemes, then at least they can come to us in time. No awareness on these schemes that provide treatment for cancer, that is there. So we should actually make them aware of it. The delays in treatment initiation once at the hospital. This is another very important finding which has come up, that once the patient reaches the hospital, again there is a lot of time taken to initiate the treatment. And this happens actually when they are advised a lot of investigations to actually stage the disease, and there is a waiting time for the investigations. For treatment also, they have to wait for the treatment, and therefore they tend to get lost to the follow-up, or they don't take treatment and they go back and take treatment for some other speciality I'm not going to take to the name of that specialities, which they actually, when they are fed up of the system here, then they go back. So sorry, please go back. Lack of awareness about schemes, benefits, and there is no citizen charter, which actually we should do and make that system transparent so that patient is aware that why he is not getting the treatment in time, or what is the problem which is there in the delay of the treatment. Non-availability of drugs for some patients despite insurance or scheme of cover. This is all the problem in the system which has to be overcome. Now, arranging money irrespective of the availability of different schemes. Even if he is empaneled, he is eligible for the scheme, sometimes the drugs are not available. So they have to do the out-of-pocket expenditure for that, and for that they have to arrange money, and then again there is a delay. Now, challenges in enrollment and documentation requirements, that is there. But now it has minimized, and within 15-20 days the patient starts getting the treatment in our setup. Now, huge out-of-pocket expenditure. Some patients have spent 4 to 5 lakhs rupees out-of-pocket, including travel, despite having cards. The major cost was on drugs and diagnostics. This is the outcome of the study. And most of the time, कभी पेशेंट्स हम लोग के पास जब आते हैं तो उनसे पूछो कार्ड है तुम्हारे पास तो इतने दिन कहाँ रहे, तो आने के पैसे नहीं थे, ट्रैवल के पैसे उनके पास नहीं थे, दो they were having that card. So reasons for dropout is the cost of treatment, dropout due to side effects. कभी उनको अगर awareness नहीं है कि ये जो हमारी problem बढ़ रही है ये side effects हैं, not that the disease is increasing, and therefore they tend to drop out from the treatment. And the traveling cost, ये भी बहुत ज़्यादा important factor है, उनको बार बार आना जाना पड़ता है, आने जाने में अगर वो arrange नहीं कर पा रहे हैं funds को, then they tend to drop out. Next. From the provider's perspective, the challenges were at community level, lack of awareness on risk symptoms, high cost for treatment deterrent and delays the treatment. Women hide their symptoms and think that it will resolve on its own. Now, prevailing stigma about cancer in the community, prevent them from disclosing and seeking help from Ashas. From the Asha's perspective, lack of awareness on the cancer screening program. उनको खुद भी बहुत ज़्यादा idea नहीं है आशा workers को कि symptoms को कैसे detect करना है, जिसके लिए हम लोग को I think बहुत regular workshops करने की ज़रूरत है. Lack of IC material on cancer care. Enthusiasm to be trained and support community to prevent cancer by learning how to assess risk and screen and refer. Requested comprehensive training on cancer care risk factor, symptoms and referrals for screening and IC material. Now, areas of strengthening, state needs to prioritize the NPCDC's program, training of all staff in DH, CHC, PHC, healthcare levels on cancer related programs, training of ASHA workers at CHC level, use of technology to create a patient tracking system which can enable MOs and staff nurses to record patients' data and follow-up. It's very important if we have this system, at least we can track where patient is being guided. Why is he not going to the right place to get the treatment right in time? Now, shifting responsibility of a screening beneficiary for PMJ and other scheme from patient to the hospital, so no one is denied entitled treatment. Next. So the areas for discussion are focus on early detection, which has to be there because there is no point treating patient in advanced stages, wasting our resources when we already know the outcome is not good for them. So mass scale awareness program should be there. YouTube people are very fond of using, so we should have the awareness things, the financial schemes on that YouTube. The FM is a very good media to make the awareness. Increase in the infrastructure definitely is needed. More radiation machines actually are needed because the bottleneck is the radiation machines where the patient have a long waiting list. The capacity building of the available manpower which has to be done, and available schemes like the BPL card or the cancer card, CMPM funds, PMJ to be made accessible, and the public should know that these schemes are available and they should not delay just because of the financial problems. Optimal and timely treatment is very, very important. If the timely treatment is not given, as per the guidelines, then everything is waste. Next. So the proposed model is that all treating centers in the state of Uttar Pradesh, which is actually termed as a state NCD cell, the tertiary level centers, they should develop their own community cancer network. District NCD clinics in their vicinity to be attached to them through the DGHS office. Capacity building via workshops and camps should be done. So, अगर हर tertiary care center अपना एक community cancer network develop करता है, so they will do their capacity building. They will take the patients directly from there if they are diagnosed. And the WhatsApp group can be made, and this I am saying because we have started doing this as a program in our KGMC, and I'll show you the pictures after this. The WhatsApp group actually is a very good media where we have made a WhatsApp group of the medical officers, the pharmacists posted in the periphery, and they are directly referring patients to us through this group. A universal software, a cancer control committee to be constituted to monitor the activities closely and conduct workshops of all treating centers regularly for communication of new ideas, success stories, standard treatment guidelines and hurdles. As in the previous session you saw that the treatment is not as per the standard guidelines. So we need to emphasize that the treatment has to be done as per the guidelines, and for that we need to conduct workshops regularly and train the people, whoever is treating, whoever is impaneled in the treatment, in providing treatment, so that they provide appropriate treatment as per the guidelines. A universal software, if that is made available to all centers, even the NCD clinics, because the patient journey starts from there only. So if in that software, if the entry is done that so-and-so patient has been diagnosed with cancer, so we can track at least where this patient, why there is a delay, why is he not reporting to us. And another very important thing is, back please, to make cancer a notifiable disease, which we have initiated a letter from KGMU so that many states, at least 15 states, they have declared cancer as a notifiable disease. If we also do that, sir, the ICMR has circulated this, that 15 states have already declared cancer as a notifiable disease. If we also do that, then the patients which are getting undiagnosed. Sir, I'll let you know, sir, I'll tell. And then we should start preventive oncology departments. This is a need of the hour because a lot of preventive oncology needs to be done, and the patients who are focusing on the treatment of the cancer, they are actually not focusing on this part of the cancer care. Next, please. So this is what we have started at KGMU, the Cancer Sahayata Kendra and Registry Unit. Room number 206 is designated for cancer registry, and in that WhatsApp group we keep telling the patients, whoever patient is diagnosed with cancer and is a proven biopsy can be directly sent to this room, and he will get full support, all financial benefits, whatever he is entitled for. And we have started conducting the workshops, and this community cancer network under the guidance of Professor Chaturvedi, who is here, and we have started this, and we have conducted 3 workshops for MOICs, for nurses and for pharmacists from the districts of Ayodhya, Unnao and Lucknow. And there was a lot of enthusiasm in these people that this kind of workshop has been done for the first time, and they have learned a lot, and now they have made a rapport with us, and they are sending patients directly who are diagnosed and have a positive biopsy. And that is the picture of the area where we are providing all dietary counseling, psychological counseling, physiotherapy, delivery of morphine, all these facilities under one roof. Thank you so much.
Thank you, Dr. Kirti. So we have 3 more discussants here, and I would request all 3 of you to kindly keep it as short as possible so that we have some time for discussion. Next, we're going to hear from Professor Anand Mishra, who is the head of endocrine and breast surgery here at KGMU, Lucknow. And he'll be talking about reducing delayed diagnosis and late stage presentation by improving awareness by way of screening and providing access to timely diagnosis, and how innovative technologies and better diagnostic tools can help us.
So very good afternoon. At the outset, I would like to thank Sachis for bringing us this very important session and giving me this opportunity to speak my thoughts and sharing on late presentation, delayed diagnosis, screening, and innovative technologies. So, I've been given the topic how can we reduce delayed diagnosis, late stage presentation. Can I have the slides? It's not there. वहीं से करो पे Yes, thank you. So I bring greetings from my university, the delegates and dignitaries who have come in for the first time in my university. So Uttar Pradesh is not a Pradesh. It is not a state only. We have a population which is only 4 countries are having more than population than us. So it's a state, it's a country, and we are talking of a country, 5th largest country of the world, if we calculate in terms of the population. And in India, if you see, 18% of the cancer cases that are reported from India, so huge burden of our national cancer burden. And every hour, 76 cases being detected. There are many challenges. Dr. Kirti has already said some challenges. Late presentation, advanced presentation, premature mortality. There is number of treatment, number of pathies available. At the periphery level, different levels, suboptimal treatment, delayed treatment, poor compliance of the patients, so many reasons, cultural reasons, financial reason. There is restricted access to the treatment in different regions. We all know that we have a heterogeneous healthcare system. There is human resource challenge. And then on the disease side, there is delayed diagnosis, lack of access to the diagnostic, lack of infrastructure of good diagnostics, lack of centralized diagnostic care, cost of diagnostics, quality of diagnostics, poor referral system, and then overall, she has discussed a lot, low awareness level of the population about the cancer and the education level of them. So what is the delay in the diagnosis, cancer management? And since I am a breast cancer specialist, I will be taking most of the things, discussing these issues, keeping in mind the breast cancer. So in breast cancer, conventionally a gap of 3 months from a first symptom to the start of treatment, then we consider it is at a delay of diagnosis. And then providers delay, if it is more than 1 month, patient has reported to me, patient is undergoing diagnostic and we are not able to start the treatment or provide the definitive treatment. So that becomes a provider delay. Last week only a paper has been published in Indian Journal of Surgical Oncology, and that has also looked on the patient delay and different factors of delay. And they have classified these delays into 4 categories. That can be primary by the patient, secondary by the doctors, tertiary by the system, and for quaternary delay is patient hopping from one doctor to other doctor or clinic to different clinic. A few years back, we had done a study on our breast cancer patients, for reason for the delay, and we found around 65% patients had delay in presentation and delay in diagnosis, and patients' factors were 41%, and providers delay was 15%. And if you we go into the detail of that study, if you see most of the patients, around 60% of the patients were younger patients, less than 40 years of the patient. And the next stage, if you see stage 2 and stage 3 cancer, breast cancer patients, they were around 65 to 70%. So I'm talking of my university. So most of the patients, they present late, they present at advanced stage, they are younger. And if patient presents late and if patient present in advanced stage, there is more pressure on the healthcare system, more treatment becomes difficult in these patients. And we tried to analyze the different perceived barriers for reasons for delay in these patients, and perceived most common delay was the misdiagnosis at the first consultation in these patients. And if reasons for delay from the patient side, if you see, they thought that symptoms will dissolve and it is not cancer, just ignoring. So second thing, if you say it is awareness, we need awareness, we need to increase the level of the education. First, we need to make better the capacity, we have to make the capacity building, we have to work on the diagnostics. Now, I say what possible intervention we can do: primary delay, secondary delay, tertiary delay, or quaternary delay. So primary can be basically by increasing the awareness, education level. Secondary and tertiary both require improving the standard of care. We have to do the capacity building. And quaternary, obviously, patient has been diagnosed with the cancer and he is hopping from one doctor to other doctor or clinic. Then it has to be, he has to understand the treatment options and facilities. So we need to make the patients aware. Now, does awareness prevent breast cancer? If we talk only breast cancer, it doesn't prevent breast cancer, but it definitely helps in staging the disease down. 90% of our breast cancer patients, or just forget breast cancer, all other cancers, most of the patients, they present at palpatory level. And just by awareness, simple awareness, we can downstage these patients. And deaths can be prevented by breast awareness, definitely. It will reduce the cost of the treatment, the treatment will be simpler, and the modifiable risk factors can be modified. Now, the ideal situation for a cancer treatment will be we do a screening, we do awareness, we pick these patients at the early stage of the cancer, and then we provide them the cancer care. And then there has to be certain aims of the cancer care, like adequate care. It has to be adequate, it has to be not be very aggressive, it has not to be less, it has to be equitable care. And what do I mean by equitable care? In next few slides I'll be talking about that. Expanding care, not only it should be available at the breast centers, it should be available at the district level, it should be available at the all level. It should not be heterogeneous healthcare cancer care. Dynamic care means when we have to aggressive with the patient, the treatment is aggressive. When patient is less aggressive, cancer is less aggressive by histopathology, we are less aggressive in terms of the diagnostic, in terms of medical oncology, in terms of the surgery. And then we should always try to reduce the burden of the cancer of the state. Now, at the hospital level, at our level, I will tell you the certain problems which we face as a specialist. Most of the patients, when they come to us, they don't have adequate or proper initial workup here. They have incomplete surgery, they have paused up the treatment, they have certain investigations, certain treatments, certain chemotherapy, one cycle chemotherapy, not adequate surgery. So I will say that paused up the treatment. And our problem in 1/3 of the patients, Dr. Chaturvedi is here, Dr. Gaurav is there, Kirti, they must all be agreeing with me that most of it in 30-40% patients, we are in the problem, how to keep that patient on the right track now. Some part of the treatment he has received, now what to do? That's the problem. And we know in the government health system, so I think we have to define the role of cancer care at the primary level, at the district level, at the super specialty level. And for that, I have a model in my mind for equitable cancer care, which I was talking. In teaching, we have MBBS, post-graduation, and super specialty level. And at every level MBBS, there is something must know, something may know, something desirable. Now, whatever is may know or desirable at the MBBS level, that becomes a must thing for post-graduation level. And whatever is desirable at the post-graduation level, it becomes must for the super specialty level. And that way we have a healthcare system also, PSC, CSC level, district hospital level, medical college level, and super specialty level, care provider level. So I think At the basic level, we should define for all the cancer, basically all 4-5 common cancers, oral cancer, breast cancer, cervical cancer, lung cancer, something must do investigation. They should do must do investigation, and they can have certain other investigation. At periphery level, all investigation cannot be done. If it is a uncomplicated cancer, straightforward cancer, simple cancer, the treatment can be started. Otherwise, that patient should go to the district level, where we don't require a large MDT team, and simpler, those cancers can be treated. And at tertiary level, we should have all difficult cases, recurrent cases, and MDT level. So, taking the examples of the breast cancer, mandatory is a triple assessment, and in triple assessment, we need to do a core biopsy in these patients. Now, core biopsy needle is costly, may require at that level, because that will not sometimes change. FISH, CT scan, MR mammogram, and bone scan, and there are certain high levels. So we can define these cancer diagnostics in these 3 levels. Now, I will take example of the ICMR. ICMR has given a list of investigations on that side. Now, if you see, the algorithm starts only with the triple assessment, cord biopsy, imaging, and a clinical breast examination. So that becomes, for breast cancer diagnostic, it becomes must-do thing. And then all other things, investigation, CT, bone scan, PET, then can be added further. Now, few years back, that was a question, how, if somebody was affected with a cancer, how long we are going to live? But now they ask when we are getting cured from the cancer. I think that's a very good thing, and this has changed because cancer care management is evolving. We have newer molecular diagnostic, we have better access. Metastatic cancer is not a death sign. It can be managed with the evolving treatment. We have targeted therapies, and we are diagnosing disease late, but it puts pressure on health system, but we are able to treat these patients. Now, this scheme was a boon for, 4 years back when it came. It has helped a lot in our cancer care patients, but there are certain challenges, and I will just list those challenges. In diagnosis, diagnostic is not part of a package in the PMJY. Molecular diagnostics, only minimum ISC we can do. Follow-up investigation scans are not covered. In treatment, OPD-based treatment not covered. Daycare is not covered. Out of expenses continues to be an issue for the family. We have been discussing this. Then certain advanced and targeted therapies. In breast cancer, only trastuzumab is available, but there are many other targeted therapies which can help the patient. These are not covered as a part of packages. Drugs, part of essential optimizing list, in NCG list, they are out of list. Another part of this scheme was the Ayushman Wellness Center. I think wellness centers for cancer care has not been utilized properly. They are at the village level, different level. Their role was in the non-communicable disease, and for cancer prevention and awareness, we can use these wellness center very well. This has not been used properly. So I think this scheme is very good. We hope that many things which are the challenges and the problems that will come and that will be solved, and we will be able to help our patient. With this, I thank you all for giving me this opportunity.
Thank you, Dr. Mishra. So next in line is Dr. Poonam Gupta. Dr. Gupta is a radiation oncologist at the Hanuman Prasad Poddar Cancer Hospital, Gorakhpur. And Dr. Gupta would be speaking about increasing access to therapies, both existing and newer therapies, and adherence towards reduced dropouts and improved treatment outcomes. Is there a need to revisit the HBP and STG?
वेरी गुड आफ्टरनून टू ऑल ऑफ यू। जैसा कि मिश्रा सर ने और मैम ने बताया है क्या प्रॉब्लम आ रही है हमें आयुष्मान भारत में पेशेंट को ट्रीट करने के लिए। फर्स्ट ऑफ ऑल सबसे पहले जो है वो डायग्नोसिस में प्रॉब्लम आती है। पेशेंट बहुत लेट डायग्नोसिस होते हैं। इसके लिए हमें वर्क करना होगा कि हम ट्रेन करें अपने हेल्थ केयर प्रैक्टिशनर को जो डिस्ट्रिक्ट हॉस्पिटल में या प्राइमरी हेल्थ सेंटर्स पे बैठते हैं, ताकि कैंसर का डायग्नोसिस जल्दी बन सके, वो हमारे पास अर्ली स्टेज में आए, ना कि एडवांस स्टेज में। जब हमारे लिए कैंसर को ट्रीट करना बहुत ही मुश्किल हो जाता है और हम केवल पैलिएटिव केयर ही उनको दे पाते हैं और बहुत ज़्यादा पैलिएटिव केयर की सुविधा हम आयुष्मान के पेशेंट को दे भी नहीं पाते हैं। और जहाँ की हम बात कर रहे हैं टारगेटेड थेरेपीज़ के लिए, बहुत सारे केसेस में जब हमारे लिए जनरल ट्रीटमेंट जैसे कीमोथेरेपीज़ एंड रेडिएशन रेजिस्टेंट केसेस हो जाते हैं, उन केस में टारगेटेड थेरेपी की ज़रूरत पड़ती है। और जो पेशेंट आयुष्मान कार्ड होल्डर है उनके लिए मालिकुलर लेवल पे जो डायग्नोसिस बनाना होता है वो इतना कॉस्टली हो जाता है कि वो पेशेंट डायग्नोज ही नहीं हो पाते हैं, जिसकी वजह से हम उनको आगे एनरोल नहीं कर सकते। और जैसा कि हम देख रहे हैं कि मालिकुलर लेवल पे बहुत ज़्यादा हमारे पास ऑप्शन भी नहीं है आयुष्मान योजना में। हर्सेप्टिन इंक्लूड हो गया है एंड मोस्ट प्रोबेबली बेवासीजुमैब भी अभी जो हमारी न्यू पैकेजेस आए हैं उसमें इंक्लूड हो गया है, बट अभी भी हमें बहुत सारे डायग्नोस्टिक वर्कअप वाले पैकेजेस और मालिकुलर लेवल पे जो टारगेटेड थेरेपीज़ हैं, जो न्यूअर मॉलिक्यूल हैं, उनको ऐड करने की ज़रूरत है।
Thank you very much. And I now request Dr. Sandeep Jasuja, a medical oncologist. He is the medical superintendent of the State Cancer Institute at SMS College, Jaipur. And Dr. Jasuja would be talking about facilitating standardized and protocol-driven care through task shifting, continuum, and improved data management and fund stacking learnings from states.
Dignitaries on the dais, my friends, a very good afternoon. At the outset, let me take the opportunity to thank our government of UP, Roche, and SS Health for giving an opportunity to interact with you. Our previous speaker has set the ball roll on for me and did my job easier to discuss about the facilities, budget, and what we are going to do in the Rajasthan and what we have existing facilities available in Rajasthan to discuss with you guys. So before that, just what we are discussing from tomorrow mornings, that this data and this and that and everything, I will not going to discuss any data with you guys, and just want to give you overview what kind of facilities a patient need, because we know that the cancer care started from the awareness to at the final stage and stage 4 disease. So awareness and screening. So what kind of, there should be a, for a patient, there should be a patient or any public populations, there should be a graded manner facility available at their doorstep. So as we know that cancer treatment, cancer care approach is a very complex approach, and they need a lot of efforts from a government setup, private setup, and also we have a limited resources, and we have a lot of, we need a lot of manpower, lot of infrastructure, and lot of fund for to care the patients. So that's why we have to be very wisely distribute our fund, our manpower, our whatever resources have with us at the graded level, like what we have to maximum strengthen at the community level care, and what we have to do at primary level care and at tertiary level and district level and so on. So coming to the community level, what we want to do in community level, what we want to do. The important point is thus cancer awareness and screening. That is the main, what we are discussing from tomorrow morning, that the patient should not come at late stage and should not come at, because when the patient come at late stage, they need a lot of fund, need a lot of latest advance, what is only we can give to the advanced stage. But if a patient will detect early cancer patient, then there is no need of this advanced and costly affair to give them right away. So simply diagnose, treatment by surgery or radiotherapy, we can get away from this disease and and can optimize our resources in these patients. So as you know that in a Western world, 60 to 70% patient diagnosed in early stages, but in our setup, what we are discussing, they are diagnosed in late stages, 60 to 70. Why it's happened? Because of even our literate people are illiterate in diagnosing the cancer patient and doing a screening. I want to ask from you guys that how many persons in all of you got the screening after 50 years? I don't think somehow anyone got 1 or 2, might be from 100, got this screening method of colonoscopy, PSA, digital rectal examination and everything. I don't think. That's why I say that literate people are illiterate even in our society, and they are not setting the role model for the general population. And you can imagine at the primary level, at community level, what the education they have. They have a lot of taboo, what we are discussing, that sometimes they have financial issues, sometimes they have taboos like अगर इसको छेड़ोगे तो बढ़ जाएगा कैंसर, अगर हम जाएंगे नहीं, अगर हमने एक बार ही कैंसर स्क्रीनिंग कराई तो लोग हमारे पे स्टैंप लगा देंगे कि इसको तो कैंसर है इसलिए स्क्रीनिंग करा रहा है. So this kind of when we are going to do a camp in lower level, this kind of feedback we got from there. So that's why I suggest one or two things in this point. That one thing, the dedicated cancer, when you do a dedicated cancer camp, you might have a lot of people for screening, because it's optional and patients don't come to you and people don't usually come to you for this. But yes, if you do a multidisciplinary, multi-specialty camps and along with that do a cancer camp, then patients don't hesitate to come to you and they want to check their BP, and also they got their screening for the cancer also. So this can be implemented at the lower level. What failure we are getting because of doing a dedicated cancer camps in the lower level, and we are getting this failure because of we are not doing a screening so much patients. Second important point I want to discuss, that we should set a role model for the community, like in US, UK, why they are getting early detection? Because of the screening method mandatory for them, for they have their report card, they have their health card. So if we can't do in the whole population, then we can just have a mandatory this screening and awareness in our government sector, government servants. We can have a report card, and when the people see that government servants are also getting screening for their health card and this is mandatory for them, then general population will have this awareness in there, and they will not hesitate and shy to come out to your center and get screening for their population. So 2 point I want to here discuss at the community level, because screening and cancer awareness, this is the 2, because the hierarchy is that when cancer starts, this is painless. Patients don't usually come to you because they are bread and butter in their family, or they are dependent on they have limited resources, they come to you in a painless stage. But later on stage, when they have a pain and they have symptom, they approach to you, and already I think we all doctors are they do agree with me that usually they are in late stage when they have symptoms. So that's why it's very important to have a good screening and cancer awareness at community level, and that we have to do this. And then some part of diagnosis like visual inspection can be done by A&M, and there should be A&M or ASHA worker, they should be well trained, and they even what we are facing challenging at the community level is when we go with the ASHA worker, they even don't know that cancer ho gaya, theek hai, ab isne marna hai, kya karna hai. This is the kind of feedback we are taking there, even from A&M, ASHA worker, they are not literate to aware them patients and population and community health. So that's why this kind of facility and this kind of sensitization of A&M and ASHA worker at lower level needed very importantly to get early detection and get early diagnosis of the patient, and so that we should avoid this whole a lot of manpower and lot of fund to spend on this advanced stage diseases. So what we need at primary level like PSC doctors should aware, and they should get the screen, like they can screen the patient at primary level. Doctors should be involved in this primary level, PSC level, to get the screening test and like visual inspection and whatever the common screenings, like for breast, clinical breast examination, if the ASHA worker suspect, or even in a village where they are posted, they should have a regular visiting at their communities. Yeah, secondary level is very important. This is the graded manner where we can a patient start journey from the community health to primary senior. Then it should be a strict and strong referral system from community to primary center to secondary center to higher center. So secondary care is like a district care, where every facility should be there. Basic facility of mammogram, sonograph, CT scan should be there at secondary, and all experts, surgeon, physician, even radiation oncologist should be there at district level to take care of these patients. So that tertiary cancer center should be a true tertiary cancer center where we get only the patient who are referred from the district level, which cannot be managed at district level, like complicated surgery, for the diagnosis, advanced diagnosis modality like NGS, like PET scan, or any costly affair should be in the tertiary center. And like bone marrow transplantation, not a simple bone marrow transplantation, not autologous, but a complex bone marrow transplant like allogenic transplant, haploid transplant should be available at the tertiary center. So this is the ideal scenario where we can go, and we should have a early stage patient which can be treated at the district level hospital, and only 10 to 20% patient should come to us at a tertiary level, so that we should not be overburdened at tertiary level too. So we know that in fact this kind of we need for the cancer patient, like if we want this is radiotherapy, chemotherapy, daycare, modularity, BMT, modular OT, operation palliative treatment department, so on. This for the treatment purpose, and for the pathology, flow cytometry, bank, blood bank, microbiology, radio diagnosis, nuclear. This is graded manner. We can install this all machine and this manpower at the graded manner, and for the optimal utilization of our infrastructure. So see the role of NGOs. NGOs are all across from community level to tertiary level, play a very important role, and you guys are doing a great job, like what NGOs are discussing, and why we are here, and we are discussing all this thing, and we are having this brainstorming session because of, I really thank to these NGOs guys and what they are
Dr.
doing
Jasuja,
for this.
it would be very appropriate for this audience if you can talk
So
about
I am coming to my point.
Rajasthan.
Now coming to my cancer care, Rajasthan present cancer care. So we currently are providing all type of cancer care to the all patient in the Rajasthan, like chemotherapy, target therapy, free of cost to the patient, latest radiotherapy machines, and also bone marrow transplant, autologous, allogenic, in government also, as well in private hospitals. Coming to the, because I overviewed, because at each level we have a subset of modalities available for the cancer patient. At community level, though we are not strong right now at community level for spreading the awareness, but yes, we are doing screening of cervical cancer, oral cancer, and clinical breast examination, and door-to-door survey by our NCD team via ASHA workers, and camps are organized by our expert, like what we have discussed before. At primary cancer PSC level, we are also, again, we have USC, some PSC, we have USC, we are doing a pap smear over there, and via visual examination. For secondary care level, we have CT scans and FNAC biopsy facility, sonography, X-ray at district level, and now we have, and even we have, important point, we have dedicated cancer care units at district levels. So in follow-up cancer treatment, the patient take the follow-up cancer treatment district level. When they come to us in tertiary level, we plan the treatment, we send back to district level, district hospital, they take care of all thing of the patients, like follow-up chemotherapy, 3 cycle, 4 cycle, and also for palliative treatment, any kind of palliative treatment like morphine and everything available at the district hospital. And also now, we are planning to install radiotherapy. Each and every district should have radiotherapy, and that is also on final version, final state, and each and every state district have a radiotherapy machine in our Rajasthan. So at tertiary cancer level, we have all kind of facility available at State Cancer Institute, SMS Hospital, as well as in private Mahavir Cancer Center, we have Mahatma Gandhi Cancer, we have. So now government have given the 250 crore rupees again to strengthen this tertiary level hospital to make it a 500 bedded at Jaipur and Jodhpur. And we have 4 tertiary center, regional center. One is the state cancer center in Jodhpur, third one is the Bikaner, and 4 is Chalawar at tertiary cancer center. And we have FDG facility available at state cancer. Also gamma camera and nuclear medicine department is there. Palliative department is already working with us. And we have also 2 seats of DM, 4 seats of surgical oncology, MCH, and 2 seats of palliative medicine department have 2 seats of PG seats. And we are also doing a bone marrow transfer state of art, even in haplodentical allogenic transfer in government setup, and also autologous transfer in private setup also too. So for the community level, we have inaugurated, our health minister sir inaugurated this mobile van which are facility of diagnosing for screening of mammogram, mobile mammogram, digital X-ray, colposcopy, pap smear, and video endoscopy, and for head and neck for the mass screening at the community level. And CM sir have announced 50 crore more rupees to strengthen this project for the Saal mobile van will be available shortly with the whole district, and they will go to the community level and will screen the patient at the mass level in the Rajasthan, and along with the help of NGOs and our infrastructure. Coming to PMGY, like similar yojana we have in Rajasthan, Mukhyamantri Chiranjeevi Swasthya Bima Yojana, and in this, this is kind of similar to PMGY, but the insurance for the family is the 10 lakh rupees insurance for their family. So already all patients, irrespective of their financial status, irrespective of their social status, they all are including in this Mukhyamantri, this Chiranjeevi Yojana, Swasthya Yojana, except Rajasthan government services people, because they have a separate Yojana for them. So in this Yojana, what we are doing in Rajasthan is, if patient come to us in government sector, what we are doing is we are just asking them for the Jan Aadhaar card, because in Rajasthan it's a Jan Aadhaar card mandate, not a Aadhaar card for the treatment. And if we get a, we take a Jan Aadhaar card, if they don't have a Chiranjeevi card, okay, we will give the treatment to them, all kind of treatment, whatever they want at district level, hospital level, or tertiary level in the, under the Mukhyamantri Nishulk Yojana, Nishulk Arogya Yojana. And we send our person to the e-meter for making this card. So each and every patient should have a Chiranjeevi card, whoever presenting to us in hospital. Because if we go to the community and we want to do this, though we are doing this also in the Rajasthan, that each and every patient should have this Chiranjeevi card. But if somehow when the patient don't have and they come to us, we don't deny the treatment to the patients, and we do in the Nirogi Rajasthan, and 1500 crore rupees for this supplement, like what are available not in the Chiranjeevi Mukhya Yojana, like immunotherapy, chemotherapy, target therapy, or the packages in second line, third line, which are not available in Chiranjeevi Yojana, or patient don't have Chiranjeevi card with them and only have Jan Aadhaar card, then we treat them under the Mukhyamantri Nishulk Arogya Yojana, and 1500 crore already given to us to procure this all treatment, centrally purchased treatment in the tertiary level center. So all facilities like FDG, PET scan, PTCR, everything is free of cost to the patient under Mukhyamantri Nishulk Janch Yojana. So practically each and every patient have their health insurance in Rajasthan, either it is a government servant or a private servant, and they can get this all access at the district level, lower level, or tertiary level free of cost, and including this latest treatment, immunotherapy, target therapy, bone marrow transplant. Recently one our private sector did a bone marrow transplant and an allogenic transplant costing about 15 lakh free of cost under the Mukhyamantri Chiranjeevi Yojana, and we are already did 100 transplant in that State Cancer Institute and SMS under this Yojana free of cost, and we have the liberty to delete and add packages depending upon the need and depending upon the requirement of the patient, like this cardiac transplantation, heart transplantation, liver transplantation, renal transplantation, or bone marrow transplant already included in this package of Chiranjeevi Yojana, and we are providing this all facility to patient at free of cost. So coming to cancer registry, what we are discussing about, the concrete data should be there for the patients patient concrete data should be available with us to plan the strategies, to plan the treatment, and to plan the focused on the budget allocation. We need really a cancer registry. We are currently conducting cancer hospital-based cancer registry at 4 places in state cancer. We have a hospital-based cancer registry. We have and SMS in Mahavir Cancer, Bikaner. So hospital-based cancer registry we are doing at our own level, but yes, we need a population-based registry, and already government have for the population-based registry, government have notified this, what ma'am is suggesting 15, yes, we are also in that 15 states where cancer is a notifiable, each and every hospital should notify their cancer patients to us and to government. So either private or government, so that's why we are at the plan of implementing this population-based registry, and for this purpose we have also done MOU for ICM, with the ICMR for population-based, and they are now planning for pilot project in 5 or 6 district for the population-based, and already we have got budget in a CM announcement for the cancer population-based cancer registry. Thank you very much, sir. Thank you.
Thank you, Dr. Jasuja. So we have heard from these eminent speakers a wide spectrum of thoughts relating various aspects relating cancer care. Of course, the PMJAY coverage about. If there are any questions or comments from the audience, this is the time. Any questions are welcome. If none, then well, at the end of this session, I would like to thank all the speakers. It's indeed, we are fortunate that we have the coverage for cancer patients under the PMJAY Ayushman scheme.